So it's time to start the next session, and I would like to welcome Professor Crosignano, Professor of Obstetrics and Gynecology from Milan. He has been the former president of ESHRE, and I guess he is well known to all of you since decades. And the title of his presentation is Prevention of Multiple Pregnancies in Assistance Reproduction. Please.
Mrs. Chairwoman, colleagues, it's a pleasure to be here, and I would like to thank Egon for the kind invitation. I was asked to make the first slide. I was asked to speak about prevention of multiple pregnancies in assisted reproduction. And it's an interesting issue because multiple pregnancy is the single most important cause of adverse neonatal outcomes of pregnancy resulting from assisted reproduction. So it's a very important thing. One of the conditions related to the twinning is prematurity. And even in this very recent paper, just published in Lancet, you see that the prematurity is linked to the risk of cerebral palsy in newborn, and you see that for a newborn born before week 30th, there is more than 10% risk of cerebral palsy. So it's really frightening risk. There are two sorts of twinning. Twins derive from two separate eggs fertilized by two separate sperm, dizygotic, and monozygotic, two individuals born together derive from one sperm and one egg. In this case, the prevalence is quite stable around the world, 3 in 1,000 deliveries, while it's quite variable the prevalence of dizygotic twinning according to the way conception or the region we are considering. One of the important role is the role of FSH in this area, because this is the cause. An excessive of FSH action or secretion is the cause of the maturation of more than one follicle, and this is linked to the use of pro-fertility drugs, increased secretion of FSH by pituitary due to gene mutation, or increased secretion due to ovarian aging. The most important, the most frequent cause, the main causes of dizygotic twinning are certainly the increased use of ART and the rise of maternal age. Looking at this slide, this shows, starting from 1882, the rise of twins. This is the twins rate for 10,000 births, while this line represents the triplets or more, higher order multiple pregnancy for 100,000 births. And you see in the States how is changed the rate of both the condition starting from 82 onward. And this is due to the use of ART cycles. Now, considering what are the techniques used in ART just leading to the increase of dizygotic twinning, one is certainly the IUI. IUI is, intrauterine insemination is one of the most frequently used technique. And for instance, in Europe last year, more than 100,000 cycles were performed using this technique. And you see, there are two ways to use the technique. Insemination in natural cycle or insemination in stimulated cycles. And due to the fact that with stimulated cycle you double practically the pregnancy rate, this is the most used technique today, and this is why if you stimulate the ovary, you increase iatrogenically the risk of twinning. IUI is still used not only in Europe but everywhere in the world for the treatment of unexplained infertility. And unexplained infertility is a very large family because it is 20% of couples after the initial workup, couples with mild male subfertility, so 20–40% of the entire setting of infertility, and 50% of those couples in whom conventional treatment have failed. So a lot of couples are candidates to the use of insemination, of intrauterine insemination. And the system works. The median pregnancy rate per cycle is in a stimulated cycle between 10–20%. Of course, you have meta results if you don't have male problem. You have, so the best result, very close to 20% in so-called unexplained infertility group with no male contribution. But you see that the twins is 20%, so very high rate. And the triplets or more, 10%. And again, this is horrible. And this is why years, 2, 3, 4 years ago, many groups started to consider to stop IUI because it's too dangerous in terms of creation of iatrogenic multiple pregnancy, or to change the way of stimulation and just confine the use of IUI in cycle mildly stimulated. And in fact, if you reduce the unitage of FSH used in stimulating the ovary in IUI cycles, these are just 10 studies published in the last 12–15 years. You see that, the pregnancy rate per cycle is still good, but if you limit the unitage to 50 units per day, you don't have triplet, and the twin rate at the end, if you use also cancellation criteria, is 10%, so it's just half of the 20% original. This is our experience in our center, 3 years experience, more than 1,000 cycles, 50 units per day, the stimulatory dose of FSH. We use antagonist at that time because it was much simple to monitor the cycle, and 63% of the cycle were monoovulatory, pregnancy rate 10%, and twins with no triplets 9.5%. Just the same result as the international group. And in order to compare the results achievable with the use of low dose and the use of low dose in connection with the parallel use of antagonists, we organized just 2 years ago a multicentric trial in Europe, and then, by the way, 2 groups were in Hungary participating in this trial, and you see the randomization, no agonist, and low dose. Oh, sorry. You see that the 2 groups are quite the same number, completed cycle, clinical pregnancy, so no difference between the use of agonist and the use of antagonist and the use of only the low dose of SHH. So, I'm sorry, this is, yes. At the end, the result is, if you, there is something wrong, because there is something, yes. No. Okay, yes. In fact, if you use the new way of organize the IUI cycle, low dose of FSH, you can have the majority of the cycle monoovulatory. You have few twins, no triplets, and the unchanged pregnancy rate despite fewer eggs suggests better quality of the oocyte. This is for insemination. Now we turn to the other very popular way to treat infertility, is just IVF. In this case, the risk of multiple pregnancy is closely related to the transfer policy. So if you transfer a reduced number of embryos, you lower the number of multiple pregnancy, of course. And this is the example, just the experience they had in Sweden. You see that when the transfer was 3 embryos in the past, in 92, 93, there were a lot of twins, but changing the attitude of transfer and transferring only 1 embryo in the period between 90 and 2004, you see that the birth rate remained unchanged, while the multiple rate went down significantly. So you can improve the system just reducing twins, just preferentially transferring only 1 embryo. This is the comparison between Swedish and American attitude. You see that in the States, the mean embryo transfer number is 2.8, in Sweden 1.3. And you see in Sweden, the multiple pregnancy rate is very low, and in the States is very high. So, if you transfer a single embryo in the majority of the cycle and use embryo freezing in order to even improve the effectiveness of the system, you can have very high pregnancy rate and very low twins rate. But now we turn to the other condition leading to twinning, the age of the woman. Woman's role in the society has changed, and now the economic cost of children is high in some area of the world. And this two facts progressively delay. Oh, sorry, this is almost automatic change. Progressively delay the first delivery in European countries. For instance, in Italy today, the age of the first delivery for a woman is 29. So it's quite changed if you compare the 26-year-old few years ago. And the same applies to Spain, Portugal, especially in the southern part of Europe. And this, it's important in terms of FSH because the FSH concentration in this age group rise, and you see this this bar report the monofollicular in black and multifollicular cycle, and you see in terms of FSH concentration, both in monofollicular and multifollicular cycle, there is a rise between 24 and 40 years, especially in multifollicular. And this is why there is a risk we consider a risk of raised dizygotic twins between 84 and 99 in some area. This is Netherlands, for instance, just in all age group, but of course much more evident in the group of women of more than 35. We know that if we increase the median age of the woman of 10 years, less than 25 and more than 35, the relative risk for twinings pass from 1 to almost 2. And this means 5-8 twin cases for 1,000 births every additional 1 year of age. So postponing pregnancy is the major factor in terms of having dizygotic twinning. And this is quite interesting because this is the example in Holland, and by far the twinning rate is much higher in natural cycle than in induced cycles, because of course many more newborn are generated in natural way compared to IVF or IUI. And you see that this is the total number, this is the natural cycle, and this is the negligible part due to IUI or IVF. So the message, or if you want, the conclusion is multiple pregnancies originated from ART can largely be prevented because, of course, you can moderate the stimulation in IUI cycle. You can use the single transfer policy in IVF in these cycles. While there seems to be no way to stop, at least at the moment, the increase in risk of natural twinning related to maternal aging. Thank you for your attention.
Thank you very much. It is indeed really an honor and a privilege for me to be here, and I'm very grateful to Professor Dick Falucci and to the organizing committee for giving me the opportunity to be here and speak about this conundrum in assisted reproduction. I must also say thank you very much to Professor Dick Falucci for providing me with the first quotation and the inspiration for me to think about this problem in assisted reproduction. And I will try to do my best to do justice to the quotation. So, we may drive nature out with a pitchfork, but nevertheless, she will always be running back. Another interpretation of that quotation is, when a decision is made to cope with the symptoms of a problem, it's generally assumed that the corrective measures will solve the problem itself. They seldom do. And so, in our quest to follow in the footsteps in the path that Steptoe and Edwards started so many years ago, I will now remind you of what Professor Archer told us yesterday about the influence of the press. And so in this quest, in trying to give infertile women the best chance of a pregnancy, these are the sort of opinions that the media have come up with. Doctors have transferred several embryos to increase chances of success, a reprehensible gamble that needs to be stopped. Women were designed to carry a single baby, not twins or triplets. IVF experts who project themselves as scientific deities, miracle makers of life itself. Some even proudly advertise the high numbers of twins and triplets they have created. This is from that eminent scientific journal in the United Kingdom, a newspaper, and the quotes were taken over a number of years. Now, I don't have to remind you about the costs of multiple births. Professor Corsignani has showed us some details about cerebral palsy, etc. Of course, there are costs to the family and costs to the health service. But instead, I'm going to refer you to some quotations from the Multiple Birth Foundation, who support families with multiple births in the United Kingdom. And these are quotes that are from patients that I will show you. So the extract from the diary of a mother of 10-month-old twins. A friend visited with 10-month-old baby. Life is so different for her. I felt a real pang of envy. I never really stop and relax. I wonder if I play with my babies enough. There's always so much to do. No matter how organized I am, I can't. I feel like my head's going to explode. I really feel I'm going to burst a blood vessel. I do want to get my independence back. And a mother of 2-year-old twins, I'm sure we'll get over this new set of hurdles, but the strain is enormous. At times they can be completely overwhelming. One feels in a total sea, just waving about and flapping and losing control. This can be quite frightening. And parents of triplets, we had no idea of the spectacular extremes of anger, guilt, and sleeplessness, and eventually happiness that would follow. It was like being abducted by a tribe of tiny, incontinent tyrants, up all night jungling babies, bottles, and nappies. Under extreme sleep deprivation, I once poured newly made porridge into the bin and poo into 3 bowls. Anger gave way to depression for both of us. And another one, more parents of triplets. I regretted having 3 children. I thought for the first time it was a high price to pay. I wouldn't be parted from them, but looking back on the way our lives have changed, I would definitely have had just one. One child, a beautiful boy, suffers from cerebral palsy, and his mother swings from numb to loud weeping, saying at one point, "I feel so guilty. I brought him into the world when he was not meant to be born. I'm failing him and the other 2." So clearly, on the basis of the evidence that we know and these very emotive quotations from parents, we should agree that the aim of successful assisted reproduction should be the achievement of single pregnancies alone, the uneventful live birth of a single healthy baby. And this was reported in the Esri report on risks and complications of ART in 2003, and again by the United Kingdom HFEA 2 years ago. The aim should be treatment that results in the birth of a full-term singleton with a normal birth weight. However, if you ask patients, and many surveys have been done to ask infertility patients whether they would mind having multiple births, then we get a slightly different picture, because you can see from this paper was reported by Professor Gleicher in 1995, and patients with infertility problems, 67% would have loved to have twins, 75% wouldn't mind having twins, and only 4% thought it would be upsetting. And even triplets, there's quite a high proportion who still would have loved or not minded having twin triplets. Quadruplets, of course, is a different story. And in fact, a paper by Van Willy was published in 2006 asking the question, is twin pregnancy necessarily an adverse outcome of assisted reproductive technologies? And in this paper, he summarized various surveys that have been done amongst infertile couples. And you will see there are many papers published now between 1995 and 2005 over a 10-year period with large numbers of couples interviewed, and still a very high proportion say they would prefer to have twins. So now I must thank Professor Crosignani, who has given me the second quote for this presentation. Qui vulpitare scilam incidit incaridi. In other words, when you try to avoid one danger, then you will encounter another. And in English, we say much less elegantly, you're stuck between a rock and a hard place. So, let's look at the other side of the coin. Now, this is a paper that was published again by Professor Gleicher recently in 2006, entitled The Relative Myth of Single Embryo Transfer. A relatively low twinning rate is reduced at the expense of declining pregnancy rates. Clinical success is a precondition for economic survival. The risk differential between singleton and twin deliveries is relatively minor in absolute terms. And this has been echoed again by the paper by Van Willy, again in 2006. Considering all arguments, we feel that a twin pregnancy that results in the birth of two healthy children does not necessarily deserve to be condemned as an adverse outcome. So what do our friends from the press have to say about this? When there was discussion about limiting the number of embryos transferred in the UK from 3 to 2, these are some of the headlines that came out. Embryo limit will dash IVF hopes for older women. Thousands of older women seeking fertility treatment will have little chance of having a baby under forthcoming guidelines, limiting the number of embryos implanted to 2, according to one of Britain's leading fertility experts. And this was echoed by the American fertility specialists, who said women who already had a poor chance of conceiving were being penalized by the policy. British women undergoing fertility treatment are being denied the best chances of success. And this quote again from a newspaper, this was in talking about the discussion about introducing elective single embryo transfer in the United Kingdom. One parent said, this nurse would rather my family didn't exist. He was speaking about Jane Denton, who was chairing the One at a Time campaign. And this policy has caused uproar amongst tens of thousands of women having fertility treatment, many of whom would risk anything for a baby. To many trapped in the cycle of hope and despair that is IVF, it feels outrageous, however they justify this, said a woman who spent £25,000 trying to have children. To a woman who's desperate to have a baby, it feels like they are having your chances. Most come to IVF believing there'll be no baby at all, so the risk of twins feels impossibly remote. When a woman has been poked, scraped, sampled, pumped full of hormones, harvested, cut open in pursuit of a baby, reason flees. And her frightened, confused partner thinks, do whatever is necessary, this just has to end. Another very interesting paper was published this year by Van Pepperstraten, who did a survey in Holland asking, why don't we perform elective single embryo transfer? What are the barriers involved? And it's a very comprehensive paper where they asked groups of patients and professionals about their attitudes to single embryo transfer. And they concluded that there are 3 important barriers to elective single embryo transfer that are important for both patients and professionals. The question of uncertainty about the advantages. Certainly it will prevent twins, but it may mean lower success rate, and the decision is not easily taken. One patient said, "When I compare it with the lottery, 2 tickets give me more chance than 1. Many patients don't know a great deal about twin-related risks. And in fact, the same may be said of some professionals. Some doctors are more apt to be more descriptive and more emphatic in their description of the risks than others. And very importantly, of course, is the question of money. Elective single embryo transfer needs a cost reimbursement scheme that favors it. In a country, in a system where there's no reimbursement or only a fixed number of cycles are reimbursed, then double embryo transfer is favored. Of course, the question of funding, one at a time, does have economic implications. In the United Kingdom, the majority of cycles are self-funded. In New Zealand, some are self-funded and some are reimbursed. And the uptake of single embryo transfer in reimbursed cycles is 63%, compared with 30% in self-funded cycles. And in the United Kingdom, couples spend about £100 million per year chasing the dream baby. Overcome with emotions, they will do anything to get results. So this year, after more than 2 years of consultation between different professional societies in the United Kingdom, the British Fertility Society and the Association for Clinical Embryologists came up with a set of guidelines which they put forward to the HFEA, who are trying to make a decision recommending elective single transfer in the United Kingdom. They conclude that success after assisted reproduction should be redefined to promote treatment that results in full-term singletons with a normal birth weight. Voluntary elective single embryo transfer has been implemented, and Professor Crosignani showed you those very impressive results from Sweden. In Belgium and France also have similar policies with no reduction in clinical pregnancy rate. But elective single embryo transfer must be combined with an effective cryopreservation program. And in the United Kingdom especially, increased funding will be essential. Professor Gleicher, in that paper questioning whether twins is necessarily a bad outcome, he also made a very important point about the older women, in that a woman who is approaching 40 may very well definitely prefer to have 2 babies in one go because she feels she may not have time to fit in 2 pregnancies. So the question is not simple. We still don't have the answers. And I would just like to leave you with this, one of my favorite pictures, the 2 pioneers with their healthy single babies. And also acknowledge the Multiple Birth Foundation, who provided me the quotations from the patients. Thank you very much for your attention.
Yes, it's time for questions on this section. Please.
Thank you very much. My name is Katona. I am a Hungarian neonatologist, and from the pediatric point of view, I was very glad to hear these 2 lectures, as I have been working in an intensive care unit for neonates, and we see those babies, triplets and quadruplets, with a very high morbidity, even mortality. So I think that to have triplets, all of them having intracranial hemorrhage and requiring shunt implantation procedure because of post-hemorrhagic hydrocephalus, this is just a tragedy, a real tragedy. And I feel that there is a moral responsibility of obstetricians as once a woman doesn't get pregnant and then she is expecting 3 babies or 4 babies, and then she has to decide which embryo should be reducted, that's an enormous difficult task. So I can understand that women don't want to kill any embryos, so these embryos shouldn't be there. That's what we feel from pediatric point of view. Thank you.
Yes, of course, you're absolutely right. And the problem is that... yes. The problem is that the infertility doctor has the responsibility to explain clearly all of these risks to the patients who are desperate for a baby. And especially if they've had many cycles of IVF, they are very unwilling to, as one woman said, cut their chances by half by having only a single embryo transfer. So the place of patient education is very, very important. And in the United Kingdom, a campaign has started in this regard called One at a Time. And we must try to convince patients that if you put 2 embryos back and have twins, then if you had put only 1 embryo back, that baby would have been a singleton. And so there is great emphasis on now trying to choose the right embryo, an embryo selection. And the consultation document from the HFEA and from the British Fertility Society has a large section concentrating on choosing the right embryo. The other very important factor is patient selection. So in our unit at Bourne Hall in particular, I have looked at our data and tried to identify, I've looked at all the data from the women who delivered twins and then tried to identify all the features that seem to be recurrent so that we can identify the patients who must be convinced to have elective single embryo transfer. But it's always very difficult, I'm sure. Professor Trosignani also had experience.
Well, I think that there are 2 main points, the doctor points and the patient points. The doctor point is having a preference of not harming the patient or look at the best efficacy of the method. Primum non nocere, it was the rule in the past. I think is still this rule valid. For patient, in fact, counseling is not enough because counseling is give to the patient information. But how many patients understand correctly this information? 10%? 20%? I don't know. So we don't have the measure of this kind of transfer of information. This is why it's a very difficult task. And at the end, of course, twins is not a terrible condition, but it's not normal condition. And this is why I am really surprised how fast we changed the horizon in 30 years' time in Europe. Just having such an increase of dizygotic twin, not for medical reason, but for social reason. So that is a very attractive matter of discussion. Thank you.
Just one question.
Kirsten Hagenfeldt from Stockholm. I would like to comment on the Swedish situation a little bit because, of course, we have seen this disappearance of triplets and we have decreased the twin rate from 23 to 6.7%. But the rules for the older women are that this is an age group where we can transfer 2 embryos because they have a lower risk of pregnancy, etc. So you have to take that into consideration. But I wanted to pose a question to Professor Trosignani. And this is about the other group, the intrauterine insemination under stimulation. This is now the problem group we have in Sweden. And we are discussing to really restrict this therapy only to IVF centers, because these are the only ones who could transfer the treatment to IVF treatment if you get too many follicles, instead of just cutting off the treatment. How do you do it? Do you think this is a good thing? Thank you.
Well, I think that it's an excellent thing. The alternative method is use mild ovarian stimulation, no more than 50 FSH units per day, and using cancellation criteria. If you have more than 2 follicles, you stop the cycle. Or in your case, you go to the IVF. But using the 2 methods, it works quite well. You have roughly less or 10% twins, and pregnancy rate about 12%, so it's not bad.
Thank you very much, and now we will proceed. Oh, sorry. This is the last question.
I have a question, Professor Crosignani. I would like to ask you, do you recommend, do you perform uterine cell class in multiple pregnancy for prevent preterm births or abortion?
Well, not surely for abortion in general, but for preterm delivery, yes. But the problem is how helpful is this kind of mechanical decision.
Okay. And Professor Eller, what is your opinion, and do you recommend, do you perform embryo reductions in multiple pregnancy?
That's very easy for me to answer, because in the United Kingdom it can only be done with a special license. So at Bornholm, I'm not aware that we have ever performed it, in fact. And it's something in the United Kingdom anyway that people are very, very reluctant to do. It has a whole other set of problems. Which warrants a lecture on its own. I know that it has very many risks. It has risk to the mother, it has risk to the babies, and there's a great psychological trauma in choosing which embryo must be reduced. So I personally am very happy that we don't have to deal with it. And we are very careful. We haven't put back more than 2 embryos for almost 10 years now. So we have had 2 sets of triplets from putting back 2 embryos. But fortunately they were both born healthy. So we were lucky.
So thank you very much. And then we will continue with introducing the next speaker, who is Professor Takeshi Aso, who graduated from Kyoto University. He was a research fellow at the Karolinska in 1973 to 75, and he has been the chairman and professor of obstetrics and gynecology in Tokyo Medical Dental University from 1989 to 2006. And the title of his presentation is Health Problems of Elderly Women, Prevention of a New Therapeutic Approaches to Osteoporosis. Please.
Good morning. Thank you very much for Brett Murray to introduce me very properly. And dear Egon and Anne, hoping you are joining us and watching us from somewhere, it is my great pleasure and honor and privilege to present my paper at the second meeting of Egon and Anne Dicfalusi's Foundation here in Szeged. The title of my talk, just mentioned by Britt-Marie, is the health problems of elderly women, prevention, and new therapeutic approach for osteoporosis. The definition of osteoporosis is a systemic skeletal disease characterized by low bone density and microarchitectural deteriorations of bone tissue with a consequence increase in bone fragility. Osteoporosis is 3 times more common in women than men. And estrogen have an important function in preventing bone loss during adulthood, and bone loss occurs as level declines, usually from around the age of 50 years. This slide compares the microstructures of normal bone and that of osteoporosis. The trabecular of the normal bone, as depicted in this panel, are thick and tightly arranged. But on the other hand, in this panel showing the typical osteoporotic bone, trabeculars are replaced by a thin and interacted trabeculars. So one can imagine that fracture in such bone easily occur even by a slight pressure. Gender difference in the aging-related mobility rates of osteoporosis of Japanese is illustrated in this slide. Women shows significant increased mobility of rate of osteoporosis after the age of 50, whereas the men, that of the man occurs after the age of 65. It has been indicated that the incidence of osteoporosis shows a distinct ethnic diversity. The number of women having hip fracture in Europe has been the greatest, and followed by that of the women in North America. In 1990, 1.3 to 1.7 million hip fractures of both women and men occur worldwide, and the estimated number of will be increased up to 3 million by 2025. It should be emphasized that Asia will show the highest absolute increase in the fracture because it has the largest population. Thus, the prevention and therapeutic approach for osteoporosis is a key issue of the health problems in elderly women all over the world. It is roughly illustrated in this slide the pattern of change of bone mass in each life stage of man and woman. The peak bone mass of men and women are different significantly from each other. Men generally are more physically active than women, and consequently the volume of muscle of men is greater than that of women. This and other factors makes the peak bone mass of men is greater than that of women. In addition to the limited net peak bone mass, women especially specifically pass a phase of rapid bone mass decrease in postmenopause period. Thus, the risk of osteoporosis of postmenopausal women increases extremely. It is clearly indicated that the decreasing rates of bone mass in early phase of postmenopause are significantly greater. Hence, the prevention management in pre-menopause is of great importance. This slide depicts the relationship between the level of bone mass before menopause and the risk of fracture in post-menopause. If a woman accumulated adequate bone mass before menopause and obtained an adequate deposit, her bone mass will stay in the zone high enough about the fracture risk zone. But a woman who did not do so before menopause, her bone mass will drop in the fracture risk zone soon after her menopause. In addition to the ethnic and hereditary factors, aging factors, and general factors and local factors have been postulated at the bone remodeling relating factors. The basic principle of osteoporosis prevention is to control the function of two major cells, osteoblast and osteoclast, in the process of bone remodeling. Based on the basic and clinical researches, the method of prevention and treatment of osteoporosis are summarized in this slide. It should be emphasized that both lifestyles improvement and medical therapies need to be conducted concomitantly in order to obtain sufficient long-lasting effect. The risk of fracture increase by aging, as indicated in these dotted lines. The medical agents shown in this slide are selected for the medical treatment of postmenopausal osteoporosis according to the age, stage of disease, complications, and contraindications. It is obvious that for every disease, prevention, not treatment, has a priority in healthcare, especially in the case of osteoporosis. Once fracture occurred following osteoporosis, it is harder to recover the physical function to the level allowing previous normal daily life. Furthermore, the cost performance is definitely negative balance in treatment than prevention of osteoporosis. For the osteoporosis prevention, the method should be easily performed with high compliance, less expensive, with minimized side effect, and most importantly, the efficacy has been approved by EBM. As one of the new possible methods of osteoporosis prevention, the effect of a dietary supplement are going to be discussed in my following presentation. As a candidate of the dietary supplement, we choose the soy product which contain large amount of phytoestrogen, which have been suggested to have some possible benefits on health care for the elderly. Various biological effects of phytoestrogens, namely isoflavone, have been reported, such as in vitro study revealed anti-cancer effect on immune system and blood flow. Effect on osteoporosis were indicated by animal experiments and human studies. In addition to the effect on menopausal symptoms like hot flush also indicated. But it should be emphasized that most of the results of these studies are controversial, and further investigation are needed to obtain the solid evidence. Phytoestrogen are classified as in the slide, isoflavonoids, lignans, and others. And isoflavonoids are the major compound of phytoestrogen, including isoflavone. Three compounds shown in this slide, diazine, genistein, glycine, belong to the soy isoflavone. Incubation of the soy product with cultured human fecal bacteria under anaerobic conditions. Only diazine is metabolite to equal. Equal was isolated from urine of pregnant horses, but it not normally present in the natural, in the urine of most healthy adults in no more than trace unless soy is consumed. Thus, equal is not a phytoestrogen because it's nor a natural constituent of plants, rather is a non-steroidal estrogen of the isoflavone that is exclusively a metabolic product of intestinal bacterial metabolism. The name of equal was designated from equine, meaning pregnant horse. The compound was isolated from human urine in 1982 by Dr. Secel as a metabolite of diazine, showing estrogenic-like substance. The characteristics of equal are summarized in this slide. Estrogen active effect, anti-estrogen effect, and partially agonist of the estrogen receptor is suggested. And selective estrogen receptor modulators, and also at the same time, it has a property of selective androgen modulators and antioxidant and so forth. Some representative report on health benefit of equal was shown in this slide. As indicated in the slide, biological active effect has been only obtained in the equal producers. This is thus essential to identify whether the women are equal producer or not when one discusses the effect of a soy product on their soy product properly. This slide shows the result of a previous study on proportion of equal producers in different generations of women in Japan. Interestingly, half of the middle-aged Japanese and men extremely less than 5 micromolar of equal in 24 hours urine. This slide shows the result of a study on comparison of urinary excreted amount of diazine, genistein, and equal in menopausal women with mild and severe menopausal symptoms. Menopausal women were divided in two groups according to their severity of menopausal symptoms. 24 hours urinary sample were collected from each case, and the amount of diazine, genistein, and equal were measured. The excreted amount of diazine and genistein of two groups of women comparing mild and severe symptoms did not show any difference, but the amount of equal of women complaining severe menopausal symptoms was smaller significantly than that of the woman with mild symptoms. Thus, the result indicates the women who can metabolize diazine to equal by their own intestinal bacteria complain milder menopausal symptoms. The beneficial effect of equal were strongly indicated. The result of a study on the effect of equal on bone mineral density is shown in this slide. In this slide, The subjects were divided in 4 groups, namely equal producers and non-producers, and those given soya isoflavone or placebo. The change of bone BMD and whole body total hip, femoral neck, and inner trunk contour are compared after 1 year's interventions. It is clearly shown that the decrease of BMD of equal producers depicted in the red bars were significantly smaller than those of the non-producer blue bars. And it was also indicated that the intervention of soya isoflavone to equal producers made the decrease smaller than that of the non-producers. The evidence obtained thus far indicates that the equal producers have some advantage in using ingested soya product by making possible their gestational gastrointestinal tract to act as a biological effect-producing organ. But on the contrary, for those who are not able to produce equal by their own intestinal bacteria, equal supplements are needed to be supplied. After numerous efforts to discover intestinal bacteria having properties of metabolizing lysine to equal without any toxic adverse effect, a bacteria named Lactococcus garbiae was obtained as one of the candidates for clinical use. Using this bacterium, equal supplements have been produced and are available for clinical trial. At the end of my presentation, I'd like to outline one of our ongoing projects. The project is a double-blind randomized clinical trial of equal effect on menopausal symptoms release and osteoporosis prevention for equal non-producers using the recently developed equal supplement. Equal non-producers, postmenopausal women were identified by their clinical status and urinary excretion amount of equal. Supplement tablets containing equal 10 milligrams per day are then taken orally, and the change in menopausal symptoms at BMD are evaluated after 12 weeks and 1 year respectively. This project has been conducted under the collaboration of Otsuka Pharmaceutical Company, a researching group. Based on our previous mentioned study, we're expecting this study will be able to add solid and direct evidence on the effect of equal supplement on osteoporosis prevention. If possible, I'm very happy to have the chance to present the result in the next coming meeting. And it is also interesting to know the situation of equal producers and non-producers and how these equal supplements are applicable for women's health care globally. In the US, the study of identical protocol will be conducted shortly. Further investigations in other countries are expected. We welcome those who are interested in joining our study. It is said that we have had 3 revolutions in nutrition. The first revolution in the 19th century concerns energy and proteins, and the second revolution in the first half of the 20th century brought new knowledge of vitamins and minerals. And the third revolution, making the unity of plant foods for promoting health and preventive diseases, has been emerging over the past decade or longer. The renewed understanding on the properties of the molecules derived from plant products may have great potential for good of humankind as like equal for prevention and treatment of osteoporosis. And this picture was taken in 1975 at the door of the Egan's laboratory, and in his office, Egan sit like this. Thank you very much.
Thank you, and we have time for 1 or 2 questions. Anyone who wants to ask? Yes?
I can do it like that. Is anything known about which estrogen receptor is being attacked by equal, number 1? And what do we know about this equal and the coagulation system? Because being estrogenic, I think it's clear, but the question is the coagulation system.
And the results so far we obtained, the receptor is beta. Yes, and we don't have enough evidence on the coagulation system now. That is what we need to study from now.
We are in time, but also we need to continue to remain in time. And now my duty is to introduce some words myself. My name is Adam Balog. I'm working in Debrecen last 20 years mainly in menopausal medicine and osteoporosis. I was really very much privileged to spend 1 year in Professor Ditzfalus's institute with some research, and this period has impacted my view on science, society, and my own life. And now about the first speaker is Professor Gyula Telegdi, who was one of the pioneers in the institute of Professor Ditzfalusi in the golden era of the fetal-maternal research. He is now a member of the Hungarian Academy of Sciences. He has been the head of the Institute of Pathophysiology in Szeged, and he is the man who has always had new eyes to research, and in his present paper he will show us his new eyes and his new topics in his research.
Ladies and gentlemen, first of all, I would like to thank the organizers, also Professor Ditzfalusy, for inviting me. I am deeply honored to be here, not only just to present the paper, but also to meet some friends going back to at least 30 years. And of course, the 30 year means memories, remembers, and also the time when we've been working on a number of projects. One of them was the fetal placenta unit, and probably this was the last work in my life when I had human project, and what I'm going to talk about this will be animal study. Of course, the 30 years, it means 30 years only in memory, and unfortunately not in the physical conditions, because the time has passed and you have to realize it. There is no way to return the time. But anyway, we are still trying to do whatever we can do. The title is Gonadotropins, Alzheimer and Beyond. But I had the feeling when after listening all these lectures that I am a little bit out of line, because most of these lectures have been involved in human study, and this will be, as I said already, an animal study, mainly mice. And Tanaka, Masaru Tanaka, is a Japanese fellow who got the MD degree here in Szeged in our English class, but he decided then to get married. He made a mistake here, and then since then he is already staying and settled down in Hungary. I don't think I have to introduce Professor Shali. We've been collaborating from time to time. He is producing a number of analogs, either analogs or anti-analogs, and it means that in the last few years, 1 year or 1.5 years ago, he contacted me that he has a very interesting compound, which probably could be tested in brain functions. I just want to mention that I left more than 20 years ago the reproductive organs, moving a little bit further up, and my interest was involved mainly in the brain function, and of course the brain function, which means that animal studies. So Shelley contacted us that he has an interesting compound, and are we willing to test it for a number of things, but he was interested in mainly on Alzheimer problems. Our story started a few years ago. It means it was 1971 when we published the first papers on this line. The question was that how the HCG, human chorionic gonadotropin, is influencing the brain, and we selected a very specific methods for this one. This was the avoidance learning. The animal has learned the task, and we treated the animal with human chorionic gonadotropin, and we followed what happens with the extinction of this learning of the memory function. And you can see that HCG is facilitating the extinction. This is the control animal. I don't want to go into methodological problems. It means that in this condition, in situation when the animals learn the task, there was no more reinforcement. So there is no conditions when would reinforce the learned phenomenon, and the animal will extinct. It means we'll forget it. So the interpretation is double, and still there is no agreement whether what does it mean in facilitated extinction. Means that the animal is realizing that he already faced in a new conditions, or the animal is already forgetting. Today I would say the HCG is really doing something, which means that the animal is probably forgetting the learned task. Then we published 2 more papers from this one, and we stopped it because at that time there was no other gonadotropins available, there was no antagonist, there was no agonist. So we stopped this line. I'm sorry. Now we turned back, and then the problem became very important and interesting, because this is, I think, it's a very well-known picture. We're showing the FSH and LH changing. This is the reproductive age, then you will get the LH surge, and in the postmenopausal period you see that a very sharp increase in FSH and LH. It's more than 10 times of the normal values. And of course we have the menopausal problems. It was already touched upon this day, that hot flushes, for example, what are they caused by the low estrogen? I think the present view is that the estrogen is the one problem which is missing, and you give estrogen, then we'll control this situation. But there is one more thing here what is really missed. This is the high gonadotropin. What the estrogen is doing is suppressing the gonadotropins, so we don't know whether the gonadotropin has anything to do with the menopausal problems, but we can go on with this one, and you see that the FSH and LH is increased. Here is a little bit better than you can see this one. This is the FSH in woman, and the man is steady. The same thing here. Here is the cyclic release in the reproductive age, and you will get against this increased LH. In the serum, again, the man is probably more or less steady. So the question is that, does the gonadotropin do anything with the brain function for a number of reasons? It was already touched yesterday by Kerstin Hagenfeld, showing that the depressive illness is twice as much in a female, and the Alzheimer's disease is the same problem. And we can go back even further up and saying that the so-called panic disease, for example, panic disorder, or even anxiety is much more frequent in women than in men. So it's still the question, is gonadotropin innocent in these problems, or it has something to do with the conditions? As I said, we got this compound from Shelley, and this is the luteinizing hormone antagonist. As an antagonist which has 5 new non-natural amino acids, like see the D amino acids, all in this place. This is much more effective than the LHRH because it's resistant more or less to digestion. And there are a number of actions being reported already, and this is one of the very important ones. It inhibits secretion of gonadotropin, inhibits FSH, inhibits gonadotropin. The LH gonadotropin also is used already in assisted reproduction as far as I know. And here are the other action of this compound: treatment of leiomyomas, endometriosis, benign prostate, hyperplasia, hormone-dependent cancer of prostate. So the question was that what this central relics is doing in the brain function, and we selected only 3 approaches. As I said, it's animal studies, and one of them was so-called anxiolytic test, it's conventionally used, plasmase, depression, force swimming, tail suspension test. And here is something which is beta amyloid, which is already the cause of this Alzheimer's disease. There are a number of questions, of course. How is it produced? Why is there? But it certainly is killing the neural elements, and this is one of the very important causes of Alzheimer's disease. And the question was that if we produce in animal beta amyloid cause defect in learning or memory function, can it be controlled or can it be reversed by the central relics? We selected male animals, male mice, because there is no cyclic release, so that the gonadotropin level is steady, and early conditions could be controlled much better than in female animals. Now here is the so-called elevated plasmase, which is conventionally used for anxiolytic compounds. Very briefly, because I think most of us who are here are not really familiar with this pharmacological test. You have 2 open arms and you have 2 closed arms. You put the animals in the middle of this, and the animal will move first, explore the place, and will stay much less in the open arm because the fear-provoking conditions. And if you have a drug which is anxiolytic, then it means that will change the percentage of the light and dark arms. What we could see here, giving central relics in different compounds, this is ICV, but you can see if we increase the dose, then the anxiolytic action is increasing also. It means that the time spent in the arm, you can measure the time, and you can measure the time you control the total time spent in these conditions. Here is another situation, I mean the same one, but we are measuring the entries, the number of entries in open time, and you increase the dose, you can again see that this dose is increasing. So it means the fear is suppressed by this central release. It means that the compound has an anxiolytic action. Let's see, the next is the depressive. This is the force swimming test. We can measure 3 different parameters: the immobility, swimming, and the climbing. And what is important, if the compound is antidepressive, then the immobility time is decreasing, and the swimming and climbing time increases. Here what you can see are this is the normal immobility time, and if you have the central relics, then you can see this is suppressing. You will get this so-called bell-shaped action of the central relics. So it's another one. This is a so-called tail suspension test. The animal is hanged up by the tail, and we also can measure the immobility time. It means that the immobility time is decreases, then the compound has an antidepressive action. As I said, it's a conventionally used pharmacological tools. If you look at immobility time in the tail suspension test, it's quite clear. You increase the dose, and you see this immobility time is decreases. So we have 2 different methods for showing that this drug has really antidepressive actions. Now let's turn to the last one. Here we have the so-called passive avoidance system, which means that the animal is placed in a light compartment. Normally the animal is moving to the dark one because it has a fear in the light compartment. Here is a revolving door. So the animal learns that it can move in the dark compartment, will get an electric shock. It means that the animal will remember, but the next day we will test it. So the time what the animal is hesitating, staying outside here, it means that how strong is the memorizing action of the animals. Now let's see what happens if the animal will. Well, here is the animal moving from the light compartment to the dark one. If we treat the animal with amyloid, you see this is the normal response of the animals. I would say the animal which had no electric shock is moving within 20 seconds from the light compartment to the dark. Now if the animal will get an electric shock and we will pull it back 24 hours later, the animal will hesitate to move in. It means that it remembers what happened, and after 140, 150 seconds will move in. Now if we have a compound which improves the memory formation, then of course it's lengthening. If the compound is worsening the memory conditions, then it's shortening. Now that's happened with amyloid. This is the amyloid which is responsible for the damage caused in Alzheimer patients. Amyloid was given after the learning task. Central relics itself has no action, but if you combine them, then it's quite obvious. It's completely knock out the amyloid caused damage caused in this memory task. I would say that amyloid was given first and the central relics was given 30 minutes. And we have a different conditions here when amyloid and central relics was given simultaneously. Its reaction is somewhat smaller. It's probably because of the amyloid and the central relics has two different time of metabolic rates, and that could explain the differences. But still, I would say the central relics can correct quite a lot of this amyloid caused damage. What can we see then? The conclusion we said we have a compound which has an anxiolytic action, antidepressive action, and is able to correct the amyloid caused impairment of memory consolidation. Well, here is the ideal compound. You could see a number of actions already have been described, and this is probably the first report showing that this drug, or I would say this compound, has a very strong beneficial action. And there is an idea today saying that the patient who is usually starting with anxiety, or let's so-called panic disorder, sooner or later will develop depression, and most of the patients, or some of the patients here from depression will develop Alzheimer. So here is a chain of events. It's quite obvious if you have something which you can look somewhere, having an action earlier than probably you can look. I don't believe that there is any drug or there will be any drug which can turn back the Alzheimer caused damage, because the cell is dead, it cannot be recovered again. What more I would say? We yesterday heard about from Kerstin Hagenfeldt, today Professor Raschel, showing that here is the pathological fracture. This paper was published quite late, it's 59, but unfortunately the picture did not change too much. So it means in females, here is the pathological fracture, the hip fractures are much more frequent females and in males. Now the question is that the problem is the estrogen which is missing, or the problem is the one, it means that the excess amount of gonadotropins. So it would be nice to have someone who would really try to see whether the LH-RH antagonist which can suppress the gonadotropin, how would influence the osteoporotic conditions. So that much about what I was going to say. Thank you.
Thank you very much for the interesting presentation, according to which the high gonadotropins are the old age poisons. Now, a few questions are invited.
I have a question. What is your assumption? Is it a direct action on one of the brain areas, or is it an indirect action by suppressing that level of gonadotropin and elevating other hormones?
Could be double. LH-RH receptors are present in the hippocampus, which is very important for the learning and memory function. And the other one, what you have in the periphery, which from the periphery can penetrate to the brain. So it's quite, my impression is that I don't have any evidence, but probably one is acting directly and another one is acting from the periphery. But it has to be investigated.
More questions? If no more question, I pass the duty to my co-chair.
Yes, dear colleagues, first of all, I would also like to say that it's a great, great privilege to be here. It was a very nice meeting, and I had a lot of fruitful discussions. First of all, I would like to introduce myself. My name is Sherban Costa. I'm the director of a university women's clinic in Magdeburg, Germany. And my main areas of interest are gynecologic surgery, gynecologic oncology, and breast cancer. Now, I would like to introduce Professor Michael Oettel from Jena. And he has finished veterinary medical school some years ago, and did then his thesis on experimental endocrinology and became a professor in Leipzig. Then he moved to the Jena Farm company. This used to be a very successful company in East Germany, and it stayed successful after the reunification. This is an exception. Most of the companies in Eastern Germany were not very successful after the reunification of the country. And later on, he became the chief of research in Jena Farm. Then also he led the research in Schering after Schering has bought Jena Farm. And now he is a little bit amused because Bayer has bought Schering. But what he doesn't know, I heard some gossips that the Dietz Falucci Foundation is planning to buy Bayer. And he told me that in this case, he immediately turns back to work.
Yeah.
Okay. Professor Oettel, please.
Mr. Chairman, no comments from my side. Ladies and gentlemen, thank you for the organizers and especially for Egon Dietz Falucci to inviting me to this nice meeting in the interesting and charming city, Szeged. My task is a review of the current status of hormone replacement therapy in postmenopausal women, but in only 10 minutes. This job is unsolvable. Therefore, I would like to focus only on few aspects, on only brief and episodic outlines. The story begins with a transatlantic conference on the left side you see Robert Greenblatt and Lemon Gray, Peter Warren and Edwin Hamblin from the American side on the left side, and Peter Bishop, Dr. Wiesenbeek and Professor de Watteville, and our patron Egon Dietz Falucci for the European side. This conference was published by the Ayers Laboratories as a long playing record in 1960. This was the beginning of the long story. Now we live in the world of the after the Women's Health Initiative study. And the gynecologists are divided in two groups. The rigorous and mission-driven opponents on one side, and the brave advocates of HRT based on a rational design on the other side. Nevertheless, the decline of the conventional HRT prescriptions will be irrevocable, which cannot be equalized by bisphosphonates and by SERMs. The Women's Health Initiative study is a permanent topic for criticism, starting with the design of the study and ending with the interpretation of failures. Every week we can find a scientific or journalistic article concerning WHI which fight against or supports HRT. One of the strongest arguments against HRT came from an American epidemiological successor study showing that the diagnosis for breast cancer are decreased after the reduction of HRT prescription. This conclusion is now abolished by a 1 million woman Italian epidemiological study which indicates that the decline of the incidence of invasive breast cancer started already in 1999. That means before the drop of HRT medication. And that the drop of breast cancer diagnosis can largely explained by a screening effect. On the other side, the reduction in fracture incidence in postmenopausal women in Oslo occurred in a period with substantial increase in the use of HRT. Future surveillance will reveal whether the last year's decline in use of HRT will be translated into increasing fracture rates. The main criticism on the automatic translation of the results of the WHI study to all HRT regimen based on the fact that the action of methoxyprogesterone acetate MPA is incomparable with the different effects of other progestins. The pharmacodynamic and pharmacokinetic profile of progestins is very, very difficult. This variability of the class of progestins is unique when comparing with these other pharmacological groups or classes. The only common feature of all progestins today on the market is a transformation of the estrogen primate rapid endometrium, the so-called McPhail assay, and not more. The answers of the gynecologists and researchers about the current situation can be outlined as follows. Critical evaluation of the results of WHI, focusing on low dosages, shortest treatment period, and suitable administration routes, non-hormonal approaches while phytoestrogens, including isoflavones, still in question, development of specific psychoactive drugs for the treatment of hot flushes demonstrated by Wyatt, individualization of HRT using pharmacogenomics, dissociated estrogens like estetrol found by Egon Desfalosi and developed by Herjan Culling-Benning. Some companies are searching for HR-beta agonists, selective progesterone receptor modulators, and as a basic task, better understanding of the interaction of sex steroids with stem cells. I will discuss some points of this list. Few words about pharmacogenetics and HRT. One example can be the findings that certain single nucleotide polymorphisms and also microsatellite polymorphism of genes for estrogen receptor alpha as well as estrogen receptor beta are the reason for the individual differences in the responsiveness to HRT. Tailored decisions can be expected on the future use of HRT, referring genetic polymorphisms of individuals. Also, mutations of the aromatase gene can deeply influence plasma estradiol levels among postmenopausal women. Doubtless, the role of pharmacogenomics in the clinical practice will grow dramatically in the near future, and therewith also for HRT. As you can see on this slide, the annual growth rate for molecular diagnostics is significantly higher than the growth rate for therapeutics. This trend will also have deep influence on the individualization of HRT. I show you as an example the estetrol, which was demonstrated by Herjan Culling-Benning in this morning, and this is a very well dissociated estrogen, perhaps an impeded estrogen. The group of Christina Gensel-Danielson is sitting here, reported that the antiprogestin mifepristone blocks breast cell epithelial cell proliferation in premenopausal women. This finding could be also helpful for HRT in postmenopausal women. Generally spoken, modulators of progesterone receptor action, the so-called mesoprogestins, with reduced abortive potential, could be a promising pharmacological group also for HRT. This class of steroids was firstly described by researchers from Jena. In our early days, we learned that the endocrine system is structured hierarchically. The CNS, or the hypothalamus, is a conductor, and the cells of the target organs are under remote control. One of the documents coming from this traditional endocrinology is the following sentence: when or where a hormone is failing or reduced in the serum, then the respect hormone must be replaced exogenously. But is this dogma true at all? We know that the age-dependent all the anabolic hormones like estrogens, DHEA, growth hormone, or in the like growth factor 1 are declining. In contrast to this, the catabolic hormone cortisol remains constant, leading to a status of relative hypercortisolism with specific consequences like immunosuppression, osteoporosis, disturbances of glucose metabolism, and so on and so forth. On the other hand, as all the anabolic hormones possess proliferative activities supporting the current debate about the oncological risk of HRT. Could be that the age-dependent reduction of the proliferative potential is a very appropriate retreat strategy of the nature, avoiding increased cancer risk in the elderly. When this assumption is true, then remains the problem of the relative hypercortisolism and the hypothetic approach for cortisol displacement in the postmenopause. We know the cortisol displacement from the therapy of Morpheus Cushing, but the compounds today on the market are not optimal. This is a more or less provocative slide showing the hypothetical model of cortisol displacement in postmenopausal women. The anabolic catabolic ratio remains on a lower level. However, it could be very interesting to test this hypothesis under experimental conditions. Moreover, we know more or less nothing about the pathological consequences of the elevated FSH levels in the postmenopause. Remember to the lecture of Professor Delecti, showing the beneficial effects of gonadotropin displacement. To the end, I would like to show two topics which are a great challenge for basic research. Firstly, the change in thinking, including therapeutic consequences for the hierarchic endocrine system to a non-hierarchic, non-linear network with many cooperating subsystems on the same level. This includes also the change from the endocrinology based on the serum hormone levels to guide the physicians for diagnosis and therapy based on the real biochemical and molecular biological processes within the cell. Secondly, improving our knowledge about the sex steroids and stem cell function. The beneficial effects of sex steroids include, for example, alteration of lipid metabolism in pre-adipocytes, modulation of bone metabolism, and skeletal maturation, and prevention of osteoporosis through their effects on osteogenic precursors. Estrogen, through their effects on osteogenic precursors, also have an effect on this. Estrogen also facilitates the mobilization of endothelial progenitor cells. On the other hand, we have to learn much more about the hormonal influences of the deregulation of the normally quiescent breast stem cells. Ladies and gentlemen, this was a mini review about some approaches for the optimization of HRT. Please forgive me for the very short presentation of the very different topics at the gallop, like the famous Hungarian hussars from Szeged. Despite the actual difficulties and qualified as well as non-qualified discussions, HRT remains one of the most attractive fields in the gynecological endocrinology. New developments are in the pipeline and totally new approaches are on the horizon, promising and fruitful scientific work for our followers. Summa summarum, HRT is not a blind alley. HRT is today on a very important crossroad, on a great challenge for the researchers as well as for the gynecologists. Thank you for your patience with me.
Thank you very much for this excellent paper. The paper is open for discussion. Are there any questions? May I ask you a question? Could you tell us what is your opinion on ultra-low dose hormone replacement in the future in terms of preventing osteoporosis, for instance?
Yes. As an animal doctor, I know. Can you understand me? We know from the phylogenesis that the estrogen is not a female hormone. The first estrogen receptors occurred in the bone fishes, not related to the reproduction of the fishes. Therefore, the first task of the estrogen was focused on the bone function. And Professor Stock knows that the Schilden researchers have found that the effectiveness of estrogens on the bone is in extremely low dosage possible, 100 times lower than the normal dosage for HRT. There is no effect on hot flushes, no effect on all other symptoms of climakia, but very sure improvement of bone functions.
After a lot of controversies and debate about calling HRT HT rather than replacement, because people in the United States think that we are over-treating, now you came to the displacement therapy. What are you proposing? Are you proposing, in fact, replacing some other hormones, or how would you see this concept of hormone displacement therapy? I missed some of the points.
This concept is hypothetical, is provocative. And concerning the cortisol displacement, the main argument against this cortisol displacement is the possibility to induce autoimmune diseases in the woman. Therefore, it seems to me that we have to have to search for specific dissociated antiglucocorticoids.
Is it also related to the metabolic syndrome and the role of cortisol?
Could be. I'm relatively sure. Yeah.
Professor Ettel, thank you very much. And I would like to ask Yuri Batfai for one closing remark or telling us what we should eat.
My main field of interest is fetal cardiotocography and phonography as well. And I am also interested in preterm burn prevention. So I will forward the chairmanship to Anastasia. not only because she's much more beautiful than me, but she's much more familiar with the topic of this session and also with the lecturers. So Anastasia, would you be so take the microphone?
Thank you, Professor Török. First of all, I want to thank Professor Diczfalusi that I'm here. I'm a cardiologist from Novi Sad, Serbia, and I'm really honored to be one of the chairs, while Professor Tomasz and Marta Katona will have a presentation. So please be so kind, Professor Tomasz Forster, who is the director of the cardiology department of the University of Szeged and the professor of cardiology also of the University Clinic in Szeged. His main area of interest is, of course, cardiovascular diseases, including prevention, also intervention, complication, and especially echocardiography. His publications on echocardiography and stress echocardiography are really world famous, and he's one of the editorial board member of the European Echocardiography Journal. So please go on, Professor.
Thank you, chairpersons, ladies and gentlemen, dear colleagues. I would first like to express my gratitude to the organizers that I can present this data here about prevention of cardiovascular complications in elderly women. Furthermore, I always astonished of physical and mental fitness of Professor Egon Diczfalusi. So, Egon, I wish you a very good health for the future too. So, coming back to our topic, yesterday we had a very nice overview presented by Kerstin Hagenfeld about morbidity of elderly women. I also like to show you some fiction and facts. What women believe is the main and major cause of female gender is, they think, is breast cancer. But the reality is that coronary artery disease is responsible for more than half of the death in women. This is an American statistics from 1999, and as you see from the graph that since 1979, among men, there is a gradual and steady decrease of mortality of cardiovascular diseases in the United States. But if we look at the curve for women, it's rather stable or increasing. So that means that there is some difference between men and women cardiovascular disease. Here are some European data. And as you see, the proportion of women dying of cardiovascular cause is larger than in men, 44% versus 38%. So this is a rather old study comparing pre- and post-menopausal women, and you see that in post-menopausal state, in any age group, the cardiovascular complications are more frequent than in premenopausal state. So that means that the postmenopausal state is more dangerous for women, and we already know that hormonal status, what can prevent them in the premenopausal state. If you look at morbidity and of course mortality of acute myocardial infarction, then you can see that women die more frequently, have more cardiogenic shock, experiencing more serious bleedings, and having congestive heart failure more frequently. So that means that the women's cardiovascular disease different. What could be the reason for that? I should say that women present to the emergency department with more often with atypical complaints. like pain in the jaw or dyspnea, fatigue or numbness of arms, which means that they don't have that typical complaints of acute myocardial infarction what we used to have among men. What about risk factors? A number of risk factors cause a comparable risk between the two genders, like hypertension, high cholesterol, metabolic syndrome, sedentary lifestyle, but some of the risk factors cause an increased risk in female gender, like smoking, high triglyceride, low HDL, diabetes, and obesity, depression. Coming back to the good and old Framingham heart study, and if we compare and the relationship between diabetes and coronary heart disease mortality, then you see that in non-diabetic patients, men have more cardiovascular deaths than in women. But in diabetic, you see there is a twofold increase among men and a fourfold increase among women, which equalize the chance to die of cardiovascular cause. You all know that exercise test is a very good and very frequently used diagnostic method to detect coronary artery disease, and if we list the predictors of false positive exercise test, you see that female gender is included in the list. Diagnostic tests to detect coronary artery disease use less frequently in women, as this graph shows you clearly that ECG, echocardiography, or myocardial perfusion imaging performed less frequently in women. Therefore, the diagnosis is also not established. These data come from the Euroheart survey on angina, and you see that exercise test and coronary angiography perform significantly less frequently, again, among women. This graph again from the same study, the Euroheart survey on angina, concerning the medical therapy between the two genders, and you see that except for the beta blocker therapy, women receive less frequently antiplatelet therapy and lipid-lowering drugs. These data are significant, showing significant difference. So, following this data, it is not a big question why women have more cardiovascular deaths or angina. So, again, I just want to point out that the cardiovascular disease between men and women is not the same. If you look at cardiology interventions, here again there is one exception, pacemaker implantation, but percutaneous coronary intervention, peripheral interventions, ICD implantation, or cardiac resynchronization therapy is given less frequently to women than to men. So therefore, the higher mortality of women can be explained by this fact. We have a good number and large-scale multi-center trials. And you see, I think all you know this kind of trials, the GC, the ISIS, the 4S, or CIBIS, and some others. And if you look at the proportion and the representation of women in those trials, then you can clearly see that it is about just 1/4 of the whole patient population or less. So therefore, all these conclusions given by these trials can be applied to men, but just rarely to women, because the representation of them is not so big. In 2004, the American Heart Association And the National Heart, Lung and Blood Institute introduced a new action, therefore, to work with women heart disease. And this was the Go Red for Women, which is still going on. And in 2005, also the European Union see the problem, and they introduced the Women at Heart movement. And also in 2005, they gave a statement of the policy conference which applied for the diagnosis and the nature of coronary disease in women. We already heard about hormone replacement therapy presented by Professor Michael Oettel. And I'm just like to share with you the cardiologist's point of view about this hormone replacement therapy. This was one of the first observational studies the nurses have studied, including a large number of women. It's almost 60,000 women were included into the study. They were quite young at age. They received estrogen and progestin. They were followed for 16 years. And finally, it turned out that a 40% relative risk reduction of cardiovascular diseases was observed in the treated group. So this gave a big move to hormone replacement therapy, but I should stress that this was just an observational study. Afterwards, they conducted multi-center randomized trials like HERS, heart and estrogen and progestin replacement study, examining the appearance of coronary heart disease events. This was a smaller study, about 2,700 patients. The ladies included in the study were at higher age, and they received the therapy against placebo. They were followed for 5 years, and as you see this from this graph, that there was no significant difference after 5-year follow-up between the two groups as concerned the cardiovascular complications. Or even though, as you see, in the first 3 or 4 years, hormone replacement therapy had a little bit higher risk than placebo. We also heard about the Women Health Initiative, and this study included 16,000 women in postmenopausal state. The study addressed the question whether estrogen alone or in combination with progestin as compared to placebo had any beneficial effect on cardiovascular events. Unfortunately, all arms of the study should stop prematurely because the risk of adverse events overcome the benefit of the therapy. So therefore, the study was stopped, and the conclusion came, and this is the evidence at the moment, that hormone replacement therapy is not useful for preventing cardiovascular complications in women. But as we heard previously, that the proper therapy is not set and not established at the moment, and I think and strongly believe as a cardiologist that if the hormone replacement therapy started in proper time, given an appropriate combination of the drugs and administered via normal route, then hormone replacement therapy might decrease cardiovascular complications. I would say might because all the evidence at the moment against and no guidelines include that, but if a good, properly conducted trial will have in the future, and then I think it might prove that idea that cardiovascular complications, even cardiovascular complications, can be decreased by HRT. So, In conclusion, ladies and gentlemen, I can say that women are at higher risk for cardiovascular complication after menopause. Women's cardiovascular disease is different as concerned symptoms, risk factors, treatment and complications. So I just want to stress that we should pay more attention to women to prevent them from an unwanted cardiovascular death. Thank you for your kind attention.
So thank you. We'll go with the questions after the session. Okay, Professor Forster. So the next speaker is Professor Marta Katona. She works at the Department of Pediatrics at the University Clinic of Szeged. She's an outstanding person in pediatrics. She specialized in cardiology, especially neonatal cardiological examination. She won many prizes, and she's doing fetal echocardiography. So please go on with your presentation.
Lady Chairman, ladies and gentlemen, it's a great privilege for me to be here and to speak about the pediatric aspects of prevention of cardiovascular diseases of elderly women. First of all, I would like to thank to Professor Diczfalusi and Dr. Bartfai for the invitation. Less and less babies are born in this region, and many of them have some chronic disease already at birth, or later they contract some kind of disease. With the tremendous achievement in cardiovascular surgery, the outcome, the prognosis of congenital heart defect has changed. At present, the commonest congenital problems or cardiovascular problems in childhood are the congenital heart defects. And among this group, we can classify into different groups. The leading cause of morbidity are congenital heart defects with left to right shunt. There are many children with right to left shunt with cyanosis, and another group, the congenital heart defects with left heart obstruction, which results in a lot of problems not only in childhood but even in adulthood. And there are some rare complex anomalies. Now more and more survive into adulthood, but previously it was very rare. A big problem in Hungary and probably in the 3 countries in this region, Serbia and Romania, the increased rate of prematurity, which results in a lot of morbidity, and even the mortality is high in this group. Chronic renal failure is common in childhood, as the second most common congenital malformations are renal malformations. Obesity means a lot of problem, it's increasing, and even systemic hip hypertension has started in childhood. There are some rare anomalies like cardiomyopathy, Kawasaki disease. There are more and more autoimmune disease in childhood, and some other disease like arrhythmia and Marfan syndrome. If we look at the etiology of acquired cardiovascular diseases, you can see that prematurity is a leading cause of morbidity. With the better survival of the very low birth weight babies, we have more and more young infants, adolescents, and now adults who have some kind of morbidity, even cardiovascular morbidity. Hypoxia during delivery, hyperoxia, we know the oxygen-free radicals can cause a lot of disease in young infants. Systemic hypertension, increased pulmonary pressure, chronic anemia, infection, genetic disorders, and inborn error of metabolism is not very rare in young infants, with all the consequences of later cardiovascular disease. We should look at the intrauterine risk factors for precocious atherosclerosis. Intrauterine growth retardation caused by hypoxia results in a later hypertension or some other cardiovascular anomalies. Diabetes mellitus is very common during pregnancy. Fetal macrosomia again results in some kind of even cardiac morbidity of the infants. and maternal obesity might result to maternal hypercholesterinemia. If we search the literature, we can find more and more articles about the fetal program, the role of the fetal programming in the development of cardiovascular diseases. Bronchopulmonary dysplasia in prematures, it's a relatively new disease. More and more babies survive with this chronic lung disease, which results in pulmonary and systemic hypertension, and they remain sick for the whole life. Obesity is a big problem in childhood. The etiology is the bad eating habits, consumption of junk food, and decreased physical exercise. And if you look at the impact, it is a frightening result. Increased cardiac morbidity is connected to obesity, and unfortunately these fat kids will die much younger than the somatically normally developed kids and children. And there are more and more evidence that fat children develop metabolic syndrome, type 1 diabetes, and even systemic hypertension. Pulmonary hypertension is a rare anomaly, but we don't know the precise incidence. There is a female predominance, and if you look at the average survival, it's very short, so 2.8. It means that we have to do an early diagnosis, and we have to try to treat them very early with endothelin antagonist, bosentan, or some other modern vasodilator drugs. Irreversible Eisenmenger syndrome is rare, but in spite of adequate surgery, cardiac surgery, some children with left to right shunt develop pulmonary hypertension, which later turns into this very severe disease. You will find young adults with Eisenmenger syndrome. Gravidity, delivery are contraindicated, as the mother could die, and even there could be a lot of fetal programs. However, it's a difficult question, as oral contraceptives aren't suggested to this population of women. The maternal risk is very high, and the termination of pregnancy is suggested in most of the cases. Kawasaki disease is a rare disease. However, in some part of the world, like in Japan, there are many families affected, so repeated occurrence is well known. This is probably of genetic origin, and if you look at the drawing, you will see that coronary aneurysm, even with sudden cardiac death or myocardial infarction, could be the consequence. There are some chronic diseases in childhood, mostly chronic renal failure, resulting from some kind of congenital kidney malformation, with all the consequences for the heart. The leading cause of death among these renal failure patients are cardiovascular diseases, left ventricular hypertrophy, pericardial effusion, hypertension, and so on. Another issue is with the better survival of leukemic patients and some other malignant hemato-oncologic diseases. Unfortunately, we have to face the problem of the cardiotoxic effect of some chemotherapeutic agents like daunorubicin. Children survive 5 years after leukemia, and finally we could lose them due to congestive cardiomyopathy. Some other rare chronic disease in childhood, some inborn error of metabolism like some enzyme defect or glycogenosis, mucopolysaccharidosis affecting the valves of the great arteries. Autoimmune diseases are increases, unfortunately, and mucoviscidosis with the right heart load, and finally core pulmonary and pulmonary hypertension. How can we detect this early cardiovascular risk in our patients? Biochemical markers can be used not only in adults but even in children. The asymmetric dimethylarginine, the so-called ADMA, is a good marker, an early marker of the endothelial dysfunction. It could increase ADMA's level in childhood, could reflect the development of atherosclerosis in adulthood. Another marker, biochemical marker, is the high sensitivity C-reactive protein. It is published in several articles that increased CRP could be associated with some coronary calcium score association and coronary artery disease as well. And another marker is B-type natriuretic peptide, which connected to an increased cardiovascular risk even in children with chronic kidney disease and chronic heart failure. So the B-type natriuretic peptide can be regarded as a potential new marker in childhood as well. Rarely used, still not part of the routine examination, the small isoform lipoprotein A. It was found that elevated small isoform lipoprotein A in children could be the risk factor in the development of premature coronary artery disease, especially when hypercholesterolemia is present. So how can we summarize our finding? What kind of message can we give you from our pediatric experience? So the optimal time of cardiac surgery is necessary to prevent the development of pulmonary hypertension and Eisenmenger syndrome and some other consequence of probably cyanotic congenital heart defects. Regular follow-up of our congenital heart defect patients are mandatory. Prevention of endocarditis with good dental hygiene, giving antibiotics in the proper time. Very important, the follow-up of our previous premature babies, as you saw, intrauterine growth retardation and premature delivery increases the risk of cardiovascular disease in adulthood. The regular cardiologic control of the kidney patients is necessary. Diagnosing and treating hypertension, which starts many times already in childhood. Prevention of obesity and controlling eating habits of our children and encouraging them to take part in regular gymnastics. So these babies, children who have some chronic disease, they won't be healthy adults. So these are a big part of the population who will contract early cardiovascular diseases in adulthood. Thank you very much for your attention.
Thank you, Marta. So Ivan Valastyan, he's a physicist and works at the Institute of Nuclear Research of the Hungarian Academy of Sciences in Debrecen, Hungary. And he took part in the Swedish-Hungarian cooperation development of the portable apparatus called Cardiotom, a mobile topography gamma camera.
Thank you very much. Ladies and gentlemen, I would like to talk about our gamma camera system, the Cardiotom, which is designed for early diagnosis of the acute myocardial infarction. The early diagnosis of myocardial infarction is very important for rapid restoration of perfusion. The advantage of the myocardial scintigraphy is shown in this paper. Carlson and his colleagues show that the myocardial scintigraphy is a gatekeeper method, and the risk of the investigation is negligible, but the method reduces the number of catheterizations. In Sweden, approximately 150,000 people have chest pain in a year, and most of these people remain in the hospital for 7 days for observation, but only few percent of these people have acute myocardial infarction. With the help of the Cardiotom, we can identify this group and this group very easily, and and we can decide that the doctor can send home the patient or can admit to the emergency department. The myocardial scintigraphy is the standard spec can be used in myocardial scintigraphy. How it works, the SPECT rotates around the patient and requires projection images. The problem with the SPECT is that it is not mobile, and the transport of the patient to the nuclear medicine department is often very difficult or impossible. And the ectomography, where a stationary gamma camera head is a detector, and the rotating slant hole collimator rotates around its own axis and provides 3D images of the heart. This is the photo of the cardiotom. So the goal, the early diagnosis of the myocardial infarction. The cardiotom is mobile and provides bedside imaging. It's fast with digital signal processing and iterative image reconstruction. The performance parameters and the spatial resolution is similar to the standard SPECT systems. More than 200 investigations were done at Karolinska University Hospital in Stockholm, and the ectomographic technique can be used other types of examinations. So this is the photo of the camera. This is the gantry, which contains the data acquisition electronics and the acquisition computer. This is the camera head, and this is the detector in the head, and this is the slant hole collimator. This is the field of view, this green, and the collimator rotates around the axis of the camera head. This picture shows a typical acquired image. Here is the heart. This is a multi-segment collimator. So the heart is projected from 3 directions in the same time. And I hope I can start it. Can you start the movie? Please go. Okay. No. Oh. Okay, so the movie unfortunately not works. I'm sorry. Yes. Can you? Yes. The cardiotom has a special field of view. If we use one segment collimator, the field of view is a cone. With multi-segment collimators, the shape of the field of view is a double cone. If we increase the slant angle, you can see that the field of view will be smaller, and the depth of the field of view decreases. The camera is mobile, and the dimension is here. The width is 60 centimeters, and the length is 1.4 meters. So a nurse can roll very easily in the hospital, this camera. And you can see here the patient positioning. He's our physicist, and he moves the camera head close to the patient's heart, and checks the position on the screen. And this camera fits the beds in the hospital. We investigated more than 40 beds, and the positioning of the camera were very easy. This is a typical picture in the intensive care unit. You can see the cardiotom here, and you can see the flexibility of the camera, because the camera supports all life-supporting equipment. The data acquisition is very simple. First, the start of the camera. This is the screenshot of the data acquisition program. First, the patient logging, entering the name, the ID, and some comments. Then the protocol determination, choosing the type of the collimator, the number of segments, the acquisition time, and the isotope type. And the next step is the patient positioning and monitoring the position. And the data acquisition starts automatically, I hope. Yes. And after the data acquisition, the reconstruction starts also automatically, and the reconstruction time is just 2 minutes. So the physician can interpret the results before the patient leaves the emergency department. Let me show you some clinical images. This is a normal heart perfusion image. This is a man. The acquisition started approximately 15 minutes after an exercise, and 18 seconds per projections was the acquisition time, and total 20 projections acquired. This means 6 minutes acquisition time, and the reconstruction time is 2 minutes, so the total acquisition time is approximately 10 minutes with the patient positioning. And another picture is a man in the intensive care unit. And here 400 megabecquerel of cardiolite injected intravenously, and the examination started approximately 30 minutes after the injection, and here the acquisition time was also 10 minutes. Yes. Other organs can be imaging with the cardiotome if the size of the organ fits to the field of view. For example, acute brain studies and identification of the stroke. In the emergency department, you can see here some perfusion images of the brain acquired with the cardiotome camera. So the advantages of the camera is that it is mobile and easy to position close to the heart, and it enables the bedside imaging, and the flexibility of the camera permits simultaneous use of life supporting equipment, and the data acquisition and the iterative image reconstruction provide images within 10 minutes from the start of the examination, and the sensitivity, the spatial resolution, and other parameters are similar to stationary SPECT systems. Thank you for your attention.
Thank you. Thank you, speakers, and congratulations for the very nice presentations. Now I open the session for discussion. Do you have any question to the speakers? Please.
Kerstin Hagenfeldt, Stockholm. I have one question to Dr. Foster and one to Dr. Cantana. And the one to you, Dr. Foster, is that have anything happened during this century with the multi-center trials? You said there were 15 to 27% women in all these trials between 1986 and 1999. And was this because the companies didn't want to have women in the trials, or was it that the ethical committees didn't want to have women in the trials? And has it changed during this century? This is my first question.
Thank you for the question. So, I think in big studies, they want to have a homogeneous population, and almost. And I would say that the exclusion and inclusion criteria strictly identify who is eligible for the study. I think you know well because you also conducted a lot of studies. Recently, I would say that more women are included in studies. So I know more studies with 40-45% representation of women in a big study, which would give, I think, a reliable results for both genders and not only for males, like with these old studies I showed you. And also heard about some studies specially designed for women. So I think this could be the future, and then should be the future anyhow.
Thank you very much, both of you, of course, for good presentations. But I would like to ask you, when you are identifying all these specific risk factors in children with different kinds of figures of letters and everything, I don't know anything about them. How do you handle it? Do you tell the children or their parents and give you a prospect about the possible risks for them? And do you do any interventions to try to stop this risk, this development of the cardiac disease?
Thank you very much for your question. If I understood you correctly, then handling these all markers, biological markers, it might mean a help for us. Obviously, these are very expensive. We cannot do it in every child, but it's not necessary. Most of the children are healthy. I try to collect those children who have already chronic disease in utero, at birth, or later. And these children, probably not all of them will have, probably prematurity. This is a very important part of the Hungarian medical health care, as nearly 10%, 9% of babies are prematurely born. So who will have earlier cardiovascular defect, these markers would help. And then obviously detailed care, checkup, ECG or advice, has lifestyle advice and ultrasonography and so on will be used during their regular examination. So not all the children, just some who have risk, and those could be screened earlier and not to die at the age of 30 because of myocardial infarction. As those who have ADMA high already in adolescence, they are candidates to develop atherosclerosis very early. Thank you.
Other questions? I have one question for Professor Forster. There are many publications recently about the post-menopausal function of the ovaries. And do you have any information about that if we remove the ovaries after 50 during a simple hysterectomy, during an operation which is not needed to take out the ovaries? Is it beneficial or is it harmful for the patient? What do you think about that?
Thank you. Unfortunately, I cannot exactly answer this question because I'm just a cardiologist and I have
What is your opinion? The audience opinion. What is good for the patient? I don't know.
And you mean to maintain hormonal therapy after ovary?
No, I mean that there is some publication in the literature today in gynecology that it is better to not remove the ovaries after 50s if there is an operation, leave back in the abdomen, because the ovaries has functioning after menopause, and there is a discussion in this field.
Yeah. But I think it highly depends on the level of estrogen produced by that remaining part of the ovarium. So
I see.
I really don't know that.
Yes, you have an opinion, I see.
No.
We know that the ovaries still produce estrogens at least 5 years after menopause, and also that you can see some follicular growth also up to 5 to even 10 years after menopause, it depends. And you also know that the ovaries still produce testosterone after menopause. And that's why the age when we recommend the patients to take out the ovaries when you do an hysterectomy has moved upwards since the risk of ovarian cancer is very, very small. So usually we don't take the ovaries in women at least up till 60, and they are allowed to choose themselves whether they want to keep their ovaries or not, also at higher ages.
Thank you. Other questions? No? Then I close this session. Thank you very much for your attention, and thank you for the lecturers as well. Thank you.
Ladies and gentlemen, the next two sessions will deal with many ethical problems, and you may think that it is not a too exciting field. In our times, it is said that the amount of new information it doubles every 7th year. So it is easy to predict that in the decades to come, there will be an enormous amount of technical innovations, improvements, which will raise many ethical questions. It will also raise economical questions. So my pleasure is to introduce Professor Stock, who is the, I dare say, ideal type of scientist who could combine practical, clinical pharmacology with a real humanistic approach to life. I don't think I have to introduce him. He spent a year as clinical pharmacologist in Sweden with Arvid Carlsson, and he became then early a leader in sharing, first in pharmacology, and then I think from 1983 he became, from 89 he was then on the executive board. And when he retired from sharing, he became the president of the Berlin-Brandenburgische Akademie von Wissenschaften, where they are also involved in a number of non-medical questions. Professor Stock, please.
The title of this presentation, which was given to me by our chairman, is of course a little bit popular and also provocative, and therefore I would rather speak about patient safety, what we know, and what should probably be done in this context. The first part of my contribution will contain some facts of adverse events, which I think are not shared by everybody. Thereafter, I will speak about specific aspects of side effects in a field which I know specifically well, and then I will and give lessons to learn, and then I will give an example where I do believe that we have not even started to learn the lesson. This will be again very provocative in the sense as I was supposed to be here. Some facts and definitions. Patient safety, and this is the definition used in Europe by the official organs. Patient safety is defined as freedom for a patient from unnecessary harm or potential harm associated with health care. The patient safety incident is an event and circumstance which could have resulted or did result in unnecessary harm to a patient. An adverse event is an incident which results in harm to a patient. And harm implies impairment of the structure or function of the body or of any deleterious effect arising from there. Harm includes disease, injury, suffering, disability, death, and may thus be physical, social, or psychological. Adverse events, which include unsafe care, medical errors, clinical errors, and health care related harm, take place in, and this is important, in all settings where health care is delivered, including primary, secondary, community care, social care, and private care, as well as acute and chronic care. Now, this definition is important because when we talk about adverse events, we primarily think of drugs, and this is definitely not correct. Many studies, and this is quite interesting, many studies in this field were performed in the United States, and they suggest that approximately 4% of patients in hospital suffer from healthcare-induced adverse events. And there's an interesting statement by the European health authorities. In Europe, and this is something which is very important when we speak in Europe, only a few member states of the European Union have collected information on the prevalence about adverse events. Of course, there is more pharmacovigilance, but adverse events as total is underdeveloped all over Europe. So, data on safety levels and associated economic costs of unsafe care are either partial in our country, in our region, or do not exist at all in many member states. This is something we should know and probably should also change in the future. There is no doubt that there are adverse events creating enormous costs for the healthcare system, and therefore pharmacovigilance is important, but by far does not cover all adverse events introduced by medical care. It's a little bit unfair when it comes to adverse events to beat only on pharma just because there are the most and the most reliable data available. Data which are easier to collect than other data, this is a given, other data from treatments without drugs. Having said that, I would like to share with you a few data which I took mainly from an interesting recent book which is entitled "To Err is Human." It has been published by National Academic Press and was composed by members of the National Academy of Science in United System in order to create a safer healthcare system or health system. And I will give you now a few slides of this. These are tables which are difficult to read, and therefore I will just pinpoint to a few of them. If we concentrate on this, 15,000 samples by trained nurses and doctors who had looked at the paperwork. Adverse events occurred in 2.9 of hospitalizations in each state. And now comes the important sentence: 32% of adverse events were due to negligence in Utah and 27% negligence in Colorado. This is an interesting number, since negligence is normally not being registered when we talk about adverse side effects. And this figure, 46% of adverse events were attributed to surgeons and 23% were attributed to internists. The correlation might be here to not only but also pharmacotherapy. This is a study from 2000 in the United States. My next slide. Again, interesting. We don't have to read everything, just look at the numbers. It's just impossible to get those numbers of Europe, within Europe. We get them mostly, as I said before, from the United States. 300 general practitioners report on incidents, 805 incidents were reported, 76 were preventable, 27 had potential for severe harm. Pharmacological management related to 50% of these incidents. Poor communication between patients and healthcare professionals and actions of others were 23% of the 100 incidents. These are now incidents only. Here again, here we are with drug complications. Drug complications were the most common. These are actually 30,000 randomly selected records in 51 hospitals in New York. Drug complications were the most common type of adverse events, 20%, followed by wound infection, technical complications, 13. 58 of the adverse events were errors in management, among with nearly half were attributable to negligence. Now, drug-related only studies. The first relevant, I think, from 74 here. All states' death certificates between 83 and 93. Medication errors, accidental poisoning by drugs, medicaments, and biological have resulted from acknowledged errors by patients or medical personnel. Similar with the next one. Boston collaborative study, 1977. Adverse drug reactions occur in approximately 30% of hospitalized patients and after about 5% of drug exposures. The rate per patient of life-threatening adverse drug reactions is 3%, and the rate caused of drug therapy approximately 0.4%. And another one, 23% of the 40 RDS were attributable to physicians' error and so on. So there is a human factor and not only a drug factor, which should be regarded very carefully. Here again, 21 hospital inpatient studies, and here 100,000 medication orders. Errant medication order. An order was considered potentially in error if it was not in accordance with standard pediatric reference. This is in children. Again, the same story also in children. And finally, of those studies, 7 studies were looked together. Almost 3,000 admissions were looked at in a meta-analysis. And it says clearly 5.5% of admissions can be attributed to drug therapy non-compliance. So these are the admissions to the hospitals. And this means $8.5 billion in unnecessary hospital expenditures in 1986. So this is, I think, the best facts which we can get currently on safety, on our data which we have worldwide, mainly from the United States in terms of drug and healthcare system safety. So it is clear safety is an issue which we should look at. It is an issue of modern drug therapy, but not only drug therapy. Both the human factor and drug therapy do have significant drawbacks. Human factor seems to be predominant. This is the first lesson which we should really learn. Negligence and miscommunication are major points why these things are as they are. Now let me switch to something in terms of reporting of side effects, and I would like to share with you a few experiences which I collected over 15 or 16 years being responsible for pharmacovigilance in a major European company, and I will concentrate on oral contraceptives, what I learned in this field. I take data from Germany, but I could easily take the same from England. It's all about the same in many European countries. And here I would like to make a few remarks on drug side effect reporting, which is essential part of our drug safety system. We know that the reporting rate under normal circumstances is between 20 or 30% of all adverse drug reactions. This is about the standard figure in Europe, and this of course is dramatically changed when there is a publication, when there is a lot of awareness to a certain drug crisis. Then of course it's close to 100%, but normally it's 20 to 30%. And there's an interesting finding which I wanted to share with you. If you look in the year 1995, and these are German data, but as I said, in England it would be exactly the same. If you look at those data and look at the recency of market introduction, and these are all oral contraceptives, standard oral contraceptives, then you see that the most recent one, 92 introduced Marvelon, has the highest rate of, for example, VTEs being recorded and being reported by our systems. Before, it was Cliest, Femovan 86, Marvelon 81, and the classical levonorgestrel containing one 72. There is a clear dependence on recency of market introduction. Now, what are the reasons for that? One reason, of course, could be decreased sensitivity, because the market knows that the thing is long time on the market. This is one explanation. The second explanation could be decreased sensitivity towards longer existing drugs on the market. It could also be negligence with older drugs, or it could be adaptation. All this could be true. It could also be true that the side effect creating individuals with the old compounds have gone from the drug and are no longer on the drug. And public awareness, of course, is something else. So when you look at reporting by the classical and established pharmacovigilance systems, you should also look at the recency of the market introduction. Only then you can judge properly what is going on. Now, if we look into the real incidence rate of thrombosis, VTEs, in OC users, and when we do studies, we usually don't care about this factor. Then you see a clear dependency of age. The younger you are, the smaller is the risk that VTE will occur. If you look at your studies which are reporting VTEs, rarely there is a clear notion on this kind of age factor. The same is true when we look at body weight. There is a clear dependence of body weight. There is rarely a very careful observation about these things when it comes to studies, when it comes to observational studies. Usually many of those things are just forgotten to be mentioned. So if we look at reporting data, we have to be very careful about confounding factors, confounders, which have to be taken into consideration when we want to have a fair judgment. I think this is the lesson which we could learn from these two few examples only. Now, when we talk about oral contraceptives specifically, then of course we can look at VTEs, we can look at many other things, but we should also look, and this is very important for the risk-benefit ratio, we should also look at something else. And the question, if this is considered properly when we evaluate reporting numbers and things like that, is truly an open question. For example, you can say that oral contraceptives induce or inhibit contraception. Yes, that's okay. But you could also say, even without contraception, that these compounds have a value in medicine. They have a real preventive type of preventive medicine type of value. You don't see ectopic pregnancies, ovarian cancer, endometrial cancer. There are a lot of things which are positively influenced. Now, if it comes to evaluation, to judgment, risk-benefit value, then of course especially in public discussions, these things are more or less gone. They are not really in a balanced fashion accepted in a public debate. This is quite interesting, and I'm not promoting anything any longer in terms of drugs. I'm out of business in 3 or 4 years. I'm just looking back what I think is something we should learn from those things. So confounding factors, and we should look without alarmism to data which we get. The third problem, which is a real tricky one, is the occurrence of very rare adverse events. If you do clinical trials with 5,000 to 10,000 patients, then you might not find the very rare things. And sometimes it needs 100,000, 200,000 patients in order to see those rare events. And this is a major problem because easily it is overlooked, and sometimes it is not well accepted by the community and by industry. But again, this is not an easy task to do that. I don't want to neglect all the other issues which are related to oral contraceptives. Just to complete the picture, we do have side effects, we all know them, and of course there are some concerns which have to be looked at very carefully, and having now the compounds on the markets in so many years, I think there's a fair judgment of what these compounds do and what they do not do. And that's one example is endometrial cancer. There's a lot of studies around showing that after several years of contraceptive use, there is a decrease in the relative risk to come up with endometrial cancer. This is one of those examples. But as you see, there are a lot of studies, and only now I think we can somehow be certain that we do not do real harm to the patient in terms of endometrial. It's a little bit different when we look at cervical cancer. Here we have a slight increase, but the longer you're away from treatment, the better it is again. And these things have to be carefully weighed against all the benefits. And there is no doubt, in times when there's a lot of public criticism, it seems to be politically correct to obey to these popular views and not to listen too carefully to your own judgment, which you have gained over a long period of professional life. And again, I don't want to make it too easy, but differentiation, deep knowledge, proper judgment and experience, and a bit of common sense from time to time is badly needed when it comes to the doctor who has to prescribe and has to talk to the patient. And again, if we are honest, are those virtues which we learn in university, which we teach in our clinical practice, clinical pharmacology, epidemiology, statistics, risk analysis, are those topics which are taken very serious in our practice of teaching young people. They are not properly linked to our classical curricula. And I would like to mention this type of knowledge, including geneticists. This type of knowledge is something which will be badly needed. In 5 years, you will get the $1,000 genome. A lot of overwhelming data will be around, and no one who can interpret it. Read the genetic code is one thing. Interpreting risk and talking about the risk, what it really means clinically, are still issues which are by far not understood by the generation of medics we have today. Enormous amount of teaching and education being needed. This is just a few lessons, I think, which we have to learn. This just to end this story on oral contraceptives. And now I would like to come to my third part, which is again, if you like it, personal, but it is part of my experience which I gathered over the last years. I will be provocative, but this is done on purpose. And the title of this part is named How Scientists Can Become Guilty, or I could also call it The Temptation to Become a Public Star, or I could also call it A Good Intention is Not Always a Guarantee for Good Performance, also in medicine. The story I'm talking about is HRT. The story began with an enormous popularization of HRT, an enormous market and marketing efforts, and a huge international global market. Here are a few figures of that. It was the notion that youth can be regained by these type of drugs. And I think some of us became guilty because they did not warn early enough, because some of the promises linked to that were not really founded on clear data. Many of the promises were based on studies with 50, 60 patients only, and we all know that in terms of preventive medicine we need long-term, huge studies. So this was mistake number one. Nevertheless, it was clear from the beginning, and the only solid data was on bone. It was clear that HRT will help the bone in osteoporosis. I think this was mentioned this morning also. But the rest were smaller studies, all interesting. Good science partly, but not enough in order to really substantiate such a huge market. And what happened then? Overnight almost, the market went down by minimum 50%, and it was the WHI study which came out, a huge study done in the United States, coming out with a statement that saying in popular journals that the risk that breast cancer will appear is increased by 26% of women taking combined HRT preparations. Now let's dig a little bit deeper. What has really happened? A WHI study was done with Prempro, with an estrogen, and a very old progestin. And if you remember Dr. Oettel saying this morning, the many progestins which are on the market share only one commonality, and this is on the rapid endometrium. They are different. They are really different entities. They attack different receptors. Anyhow, this was the study. It was a huge study, 16,000 postmenopausal women, randomized, and the idea was to look for primary prevention of coronary heart disease. This was the intention. Now let's look at what patients have been included in the study. The patients were mean age 63 years. In Europe at least, not the classical age with HRT. Most of them were smokers. A lot of hypertensive patients were in. Statins were part of their treatments they had. They had a cardiovascular history, a disease history before. They were obese, and there were also diabetes in that. It's a classical cohort, but probably not the cohort to look really at what should have been looked at. But anyhow, the result was overwhelming. HRT is now in miscredit, and this morning we talked about if it is at a crossroad or at a dead end, and I share Dr. Oettel's view. It is at the crossroad. We have to think and document much better than we did probably in the past. But there is no doubt that the medical need is still there, and the data are not gone, which need and call for something for this huge cohort of people. And I think there is a huge effort needed in research, in clinical research and in basic research in order to come up with something which helps us in this, I call it a desperate situation. Now let me share with you, before I come to my end. The study resulted not only in the decrease in this market of HRT, it resulted in a dramatic wave of anxiety in women, an enormous part of anxiety in medical doctors, and it was all introduced by by publication in newspapers before the medical experts worldwide could seriously discuss about those facts. So when we talk about medical safety, we have to be very careful where the discussion takes place. We cannot avoid public discussions, but we have somehow be very concerned how we discuss certain things. And now let me make a semantic exercise with you. The WHI study, and now I would like you to read line number 3. It showed in absolute risk terms an increase of breast cancer, which was in the untreated population 30, and it went up to 38 in the treated group per 10,000 women years. That was the data. Now, you interpret the data and come to a relative risk by dividing 38 cases to 30 cases. And then you come up with a relative risk, and now a second line, with a relative risk of 1.26. Under normal circumstances in epidemiology, epidemiologists start to be warned at a factor of 3, 2.5, and 4. Then they are really warned. If there is something below 2 and there is no biological evidence, solid evidence, then they do not even consider that as a signal. But these 1.26 were taken as a fixed number, and now comes the real issue. Now read the first line. We all were reading in the newspapers that increase of breast cancer risk by 26%. Mathematically correct, no doubt. But if you know the absolute risk, you know how language can change perception. One could also have said, and now I go to the other line, this is one extreme which I do not like, but now I come to the other extreme which I do not like either, but which one could have said also. Line 4. In 8 of 10,000 women using HRT, there's a risk of breast cancer diagnosis. It's 0.08%. And you could even be more sophisticated and saying 9,992 women out of 10,000 under HRT, and these are 99.9% under HRT, there is no risk of breast cancer. This is as unfair as the increase in breast cancer risk by 26%. And you know, and we all know, that our public debate was exactly dominated by this figure. Now, why do I say that we have to learn the lesson? I deeply believe that scientists, we as scientists, especially scientists linked to patients and their concerns, have to be very careful how to interpret and how to use language in certain instances. And we cannot just copy what has been said in popular newspapers. This is not our duty. Especially in drug safety, we have a very specific and individual responsibility to look very carefully at the data before we communicate and before, without thinking, we really talk about those issues. I'm not fighting for HRT any longer. I'm just making clear how dangerous language and how dangerous selective reading of data can be, and how we can then destroy a field which probably is badly needed, and probably we will come back one day, as Dr. Edel also suggested this morning. Conclusion. I think, especially in Europe, not only there, but especially in Europe, we still need to build a competent vigilance system, not only pharmacovigilance, a vigilance system on adverse drug effects. I think we have to be very diligent about building a proper and clear, transparent reporting system. We have to be aware of the pitfalls, which some of them I tried to mention. We need to train our people, to train ourselves, that we are able to, for a qualified judgment, and we must be prepared for continuous education in this field, because life and science and everything of this kind is changing. Of course, we need seriosity and strictness when we find failures, no doubt. but we also need intellectual strictness when it comes to trying to be politically correct only and not following the scientific pathway, which somehow we know that there is this pathway and we would like to follow that. And we should always avoid, when we are linked to this kind of business, we should avoid alarmism. And we have seen a lot of alarmisms in the past, and then we had to cope for many years to come over the results of this alarmism. Thank you very much for your patience.
Ladies and gentlemen, distinguished participants, for practical reasons, I have to do a double option since the very beginning of my speech, and I will restrict my speech to bioethics and societal mutual interaction during the last 40 years and only within sexual and reproductive health areas. A good approach of these is to choose three important examples on how medical ethics interacts with society. And to demonstrate the most powerful interactions between these two entities, I'm going to select three important institutions, at least in my country, Portugal: non-governmental organizations, Roman Catholic Church, and the political establishment. And we will see how they have interacted, not necessarily in a comparable way, with oral contraception, IVF, and stem cell research. So two areas of the past and one area of the present and probably, hopefully, of the future. 40 years ago, on July 25, 1968, after at least 2 years of the then Pope hesitations and contradictions, the world was surprised with the Humanae Vitae encyclica signed by Paul VI. Oral contraception and condoms were forbidden for Catholics. Only the so-called natural methods, the so-called Oginochnaus method, was allowed for Catholics. This teaching is still defended by the actual Pope Benedict XVI, as he did in his speech in Rome last May 10, 2008. However, since between 63 and 66, first John 23, then Paul VI himself, have assembled a special commission to study the interactions between birth control, as was designated, and its ethical aspects. Among different priests, cardinals, sociologists, wise men and women was André Hellegers, obstetrics, and the future founder of the Kennedy Institute of Ethics at Georgetown University. 80% of the commission, designed by the Pope himself, was in favor of the pill. However, Paul VI ruled against them. As we know, a huge probably majority of Catholic women use either the pill or use the condom, and therefore reject the church edict. Nowadays, not 40 years ago, nowadays most people do not care about this situation, which confirm probably how some ethical values can change with time. And what was unethical becomes acceptable a few years later. This is a very important question because some ethicists believe and defend that those human values that make life worth and cannot be quantified in many terms are universal and do not change. So, do human acts, or at least some of them, have an intrinsic value by themselves? Whatever the answer was and is, later during the 80s, with the coming of the AIDS epidemic, the Catholic Church keeps rejecting the condom, with the result of incredible misery and death. On the whole, we can say that the pill research, I insist, was conducted without too much strong ethical criticisms, and under the enthusiastic support of outstanding scientists like Pincus, Chang, that I had the pleasure to know himself with Professor Dix-Falusi in Lisbon 20 years ago, a few months before he died, and John Rock. John Rock was himself Catholic, and he was the chief of the gynecological and obstetrical department at Harvard Hospital, but also with the important, essential support of Ford, Rockefeller, and Worcester foundations in different means. Probably one of the main questions under all this discussion is what is or was wrong in this sexual ethical polemic that made so many people unhappy, guilty, and insecure. Basically, inside the church itself, there were two opposite conceptions of the ethical of human contraception. One, the so-called classical one, still defended by the Pope and by the Roman Curia, saying that in each coitus, human nature has to have the unity between the sexual and procreation ethic. So the pill is forbidden, the condom is forbidden, the coitus interruptus is forbidden. But there are also Catholic people, and not only Catholic people, that think that technology, science, research, innovation are part of the human nature. So human nature is not only the biology as destiny, but this is absolutely allowed to the human being. Whatever we choose for our personal option or scientific option, we certainly agree that one of the main issues undermining this ethical opposition and discussion has to deal with the female sexual pleasure during the sexual relationships. Now I would move to my second example, discussing some ethical, quite briefly, some ethical problems related to IVF. Unfortunately, Professor Robert Edwards is not with us, but I would like to start quoting 2 or 3 examples written by himself and Patrick Steptoe in his book, A Matter of Life. When in April 71, 7 years before Louise Brown was born, the first IVF baby, they applied for fundings to the British Medical Research Council. They received, after several months, they received this answer: no. We have serious doubts about ethical aspects of the proposed investigation in humans, especially those relating to implantation of human oocytes fertilized in vitro, which were considered premature in view of lack of preliminary studies on primates. Another example occurred a few months later, 6 months later, October 71, so roughly still 7 years before Louise Brown was born, an important meeting in Washington under the title Fabricated Babies, the Ethics of the New Technology in Beginning of Life. And here it was not only an organization like the British Medical Research Council or the Catholic Church that was against. People who were against them were 2 famous scientists, James Watson and Leon Kass, that would be much later be famous as a president of the President Council of Bioethics appointed by George W. Bush 5-6 years ago. He is no more. During this meeting, James Watson, that was well known, as we all know, he had received the Nobel Prize because of the discovery of the DNA double helix in 1953. James Watson said, criticizing Robert Edwards' innovations, you can only go ahead with your work if you accept the necessity of infanticide. There are going to be a lot of mistakes. What are you going to do with the mistakes? And Leon Kass, they will be never certain the baby will not be born without defects. We certainly have to remember that during the 50s and the 60s, people were extremely concerned and afraid because of the huge disaster of the thalidomide. We have certainly to be present that that was extremely important. But we should also keep in mind that later on, the scientific community and the society on the whole accept these IVF technological innovation. Although few people predicted catastrophic and dramatic results, such as monsters, fortunately, this was never to be. My last example concerns the embryonic stem cell research, where, so far, and contrary to the previous examples, no clinical results have yet, hopefully, been demonstrated. As we know, this is an extremely promising field. Unfortunately, and more than in the previous last two examples, a complex and sometimes obscure entanglement of interests of scientists, politicians, industry, and church still occurs. Certainly, mistakes and exaggerations have been done by both sides. Probably some of the raised expectations were too high. We do not know, as some expect and defend, if this is the way to solve actual problems like Alzheimer's disease, Parkinson, diabetes, and myocardial infarction. Neither do we know how long the gap between classical research and clinical results is or will be, if ever. Anyway, at least a better understanding of some pathologies and mechanisms will be obtained, and this is already certainly quite positive. As we all know and have learned, George W. Bush banned federal funds for embryonic stem cell research since 2001. And in 2005, the huge ethical fraud of published data in the extremely good journals did a lot of misery to all these questions. Anyway, an open question persists. Is an embryo in vivo the same than an embryo in vitro? Is an embryo in vivo, either in the tube or inside or implanted in the uterus, the same than an embryo in vitro in a plate? Is it the same? Do we recognize or not that a pregnant woman has an essential and specific contribution for the embryo destiny, development, and viability? And an endocrinological point of view, as Professor Eggs and Dixfalusi learned us since the 70s, also immunological point of view, emotions, certain, psychological, but nowadays we speak more and more about the epigenetic and the importance of each woman in the epigenetic of his embryo and baby through gene regulation and activation. Leaving behind this endless discussion due to its emotional, religious, and even dogmatic aspects, I would like to go forward with a brief reflection about science, nature, and their limitations. If, as Francis Bacon wrote, science is power, probably we can agree this happens because science seeks the truth and the knowledge of all nature, human nature included. I do not say that science and technology development are the only keys to prevent suffering and to achieve a better world where universal human happiness, whatever it is, if it exists. I am aware that progress can be rather ambivalent, ambiguous, and that not all technological innovations should ethically be possible, lest to be considered as an ideology or even nearly as a new religion. On the other side, science is not the total explanation of reality, neither the only expression of human creativity, even if we can have a lot of aesthetics and art when performing science. Aesthetics and art have an enormous importance and meaning in our everyday life, and science alone cannot explain it on the whole. Also, some people think that there is a transcendental meaning of life that science cannot explain. Coming back to the three aforementioned areas of my talk, and not forgetting that science abuses, even before sexual and reproductive health, even outside sexual and reproductive health, have, unfortunately, classical and dramatical examples during the Nazi regime, done by the American doctors in Tuskegee and Willowbrook in the 50s and the 60s. The famous Henry Beecher, American doctor that, having denounced the atrocities of Tuskegee and Willowbrook with his famous paper of 66, even so, he collaborated with CIA in Germany doing awful things to German prisoners. And later on, the huge and awful fraud of the so-called South Korean team with Wang, which was the boss, with the publication of fraudulent data obtained with an unethical way. But in the sexual and reproductive health, we have faced involuntary sterilization. I wonder if it is a scientific abuse and malpractice. I think it is, certainly, no doubt. Post-menopause mothers, probably not all in this room have the same opinion, but certainly ambiguous relationship with a lot of scientists with pharmaceutical companies. The relationships themselves are not at all wrong if we declare, of course, our conflict of interests when they exist. Probably because of all of these, Leon Lederman, Nobel laureate of physics, and I thank this quotation to Professor Dixaluzi, wrote, "A depressing number of scientists are greedy, unethical, selfish, egocentric, intolerant, racist, narrow-minded, all the way to the evil. Scientists cheat, plagiarize, work on poison gases or for tobacco companies, advise and support tyrants and dictators." Not all, a few, but we should don't forget that it exists. So it's true, medical doctors and scientists are not always people with a higher ethical standard than anyone else. However, with all its abuses, frauds and malpractices, science is self-correcting, and all misconceptions, sooner or later, are subject to revision and correction. No other human activity has these characteristics, even when we do need to replace an old paradigm by a new one. Nowadays, because of the compulsory regulations for seeking informed consent from patients and obtaining approval from ethical committees, the ethical standards of present clinical trials are significantly higher than they were just a few decades ago. In any case, and I do not want to go inside the future presentation, its contents I don't know, in any case we should never forget that social inequity on the access to technological innovations is still a huge challenge. In sexual and reproductive health area, it happens, for instance, within assisted reproductive technology, where in several European countries, most couples, most women do not have a huge access. And probably it will certainly happen in the future with stem cell research applications. Let me conclude. It's my last slide. While some people are afraid of unlimited possibilities of science and medicine, some aspects have to be clarified. Convictions of faith have no place in questions of science and medicine. Nature, included human nature, has to be investigated without philosophical or theological reservations. And mainly, as Professor Dixaluzi told us with his motto, we should never give up hope, science, and empathy. Thank you so much for your attention.
Greetings and thanks to Egon Dix-Falusi for the kind invitation to come today and spend time at this meeting with you in Szeged. It's a great privilege, first visit to Szeged, and I hope to see a little more of it before going back to the UK. The subject of our meeting is a very fascinating and important one, prevention in women's health. And I want to take the theme of empowering women because empowering women throughout the world is fundamental to the promotion of women's health. Raised status, poverty alleviation, and provision of microcredit are just some of the things that are among the most highly valued actions to be encouraged in this particular area. And like my predecessor who spoke before me, I'd like to take 3 examples also to consider with you briefly and to see what lessons can be learned from 3 summits that have been held over the past couple of decades, because they've each of them led to conflicts which have had to do with ethical demands and economic decisions. And in this context, I'd like to refer to that very distinguished Nobel laureate, Denis Gabor, who came from this country, I believe, and was the inventor of holography, who once said, "The future is difficult to predict, but it can be invented." And so the question that we have is, what are we inventing for the future? And how have these summits helped in developing our future? So the 3 examples are the UN International Conference in Cairo in '94, the UN Millennium Development Goals in New York City in 2000, and the United Nations Framework Convention on Climate Change, the Kyoto Protocol of 1997. As you can see, I'm wanting to try to just broaden our discussion, our reflection as we come towards the end of these formal presentations today. And so if we take, first of all, the ICPD in 1994, you remember that it signaled the seriousness of the global population growth rate, and it was recommended that family planning needs of their populations as soon as possible should, and in all cases by the year 2015, seek to provide universal access. And here we have the plot between contraception prevalence rate and maternal mortality rate, showing the importance and the significance of contraception. And we see also here that no longer was population to be discussed in terms of national population figures, but this was a world that would concentrate on the rights of the individual, and particularly women, to decide when and how often to have children and how many. And this was the dream of Cairo, let me remind you, that was that women would soon be empowered with civil, political, and legal rights, and this would offer increased opportunities. And we know how important that is in terms of human fertility. Now, on the right here, you can see the all-party report from Westminster last year in the UK, entitled Return of the Population Growth Factor, which says that over the past 10 years, the focus on population has been lost. At Cairo, 179 countries agreed upon a broad agenda of family planning, which is estimated to cost about 15 billion euros annually by 2005. But at today's prices, about 1 billion euros are required annually to supply the support of contraceptives to low-income countries, but the actual support from high-income countries and middle-income countries has stalled. And we're familiar with that picture, and it's now only about 100 million euros. Now, this report from Westminster also highlighted the international parliamentarians' commitments to do something in this area of great significance. And the report recommended that donor agencies and governments and World Bank and Development Bank should increase their support for family planning. And the reason for this, of course, is in this critical and all too familiar picture. So in summary, the Westminster report, international support for unmet need, about 1 billion needed, 100 million euros provided, population growth rate, reproductive health, development age is only 30% of the target, available contraceptives, shortfall in Africa, 1.9 billion. And from this familiar picture that we all know about and we all have sleepless nights about, I hope, we can see that we're looking here at UN projections that go up to figures of about 10 billion by about 2050, And the question is whether we're going to go up to 10.5 billion, or whether we're actually going to be able to control that growth and keep it at somewhere below that, which of course would be a much more sensible target to aim for. So the first example that I want to talk about, that I've been talking about here, reminds us of the ideological and the political negativities that are implicit in these discussions, as my colleague said just before. And it's pushed women's health from that position of top priority. So let's move on to the second. That was the first summit. The second summit dealt with the Millennium Development Goals. And we're reminded in this context that no country, with the exception of a few oil-rich states and of some parts of India, have ever risen from poverty whilst having a high fertility rate. And 80% of the low-income countries believe that their population growth is already too high. So let's just remind ourselves of the Millennium Development Goals from the UN, which agreed to set these goals and targets for combating poverty, hunger, disease, illiteracy, and so on. I won't go through these because these will be all too familiar. Surprisingly, the Millennium Development Goals didn't include specific demographic or reproductive health goals or targets in their formulation, and of course that's been a matter of discussion ever since these were introduced. But the UN now has approved that the question of population growth must come back onto the agenda, and calling for universal access to reproductive health care by 2015. And so, the Executive Director of UNFPA has said, 5 years after the Millennium Declaration, the world has reaffirmed the need to keep gender equality, HIV, AIDS and reproductive health at the top of its agenda. So this second example, which as I say didn't include reproductive health initially, this second example of course it includes empowerment of women, but not specifically in connection with population growth. So this second example speaks to us about the moral imperative to make voluntary family planning universally accessible, particularly in the poorest regions of the world. And it speaks to us of the clashes within the international community to meet which has failed to meet its commitments to women's health in low-income countries. So let's look at the third one, which is probably the most troubling summit. We've noted that high fertility rates may contribute to the potential for civil conflict because of pressure on land, water resources, high rates of youth unemployment, and of course the migration issue. Now, global warming is something that is with us and which the majority of scientists believe the science is now secure, and that in fact over the last 400,000 years we've seen these fluctuations in CO2, but now they're way up here at 380 parts per million, showing this dramatic rise since the start of the Industrial Revolution, giving global warming projections of anything from 2 to 5 degrees. And each of these factors which we've been considering so far are going to be affected by global climate change. And so the Stern report, which was published in 2006, has drawn our attention to the question of how serious is it going to be? And so Nick Stern would say that if we can hold the temperature rise to something like 2 degrees, then we may well see in terms of food some falling crop yields in some areas, but possibly rising yields in others. With water, small mountain glaciers will disappear, water supplies will be threatened, ecosystem damage, of course, extreme weather events beginning to increase, risk of abrupt and major irreversible changes starting to increase. But if we can't hold it at 2 degrees, by controlling and mitigating CO2 and greenhouse gas release, if it goes up to 3 degrees, or if it should go up to 5 degrees, this is an area that the planet has never seen for hundreds of thousands of years, and we do not know what it will be like at that sort of temperature rise. So these climatic shocks cause setbacks to economic and social development in low-income countries, even with temperatures with a rise of only 2 degrees. Now, the international efforts to grapple with this problem, which is inevitably going to affect the 2 previous issues that I've just been discussing, has not been very successful. Kyoto has been ratified, this protocol, by over 180 countries, but as we all know, there is one country that has not yet ratified it, the United States of America, which of course is crucial in this whole area in terms of leadership. In addition, we know that the Kyoto Protocol has only been symbolic. It's been a failure because initially it was intended to save 770 million metric tons of carbon emissions, and because of all the political wrangling and debate that's taken place, we're going to end up with emitting more than 4,480 million tons of carbon, more than was projected. So there's been failure here also in terms of what this international summit could achieve. So the estimates for today are that for preserving the Earth and cutting emissions starting now would cost us about 1 to 2% of GDP. And the question is, are we prepared to spend that? Because the cost of climate change, says Nick Stern, is going to be 5 to 20% of GDP. And so the dilemma, the economic decision and the ethical demand is to decide whether to act now in order to make savings in the future, or whether to wait until we're much richer so that we can afford to make those economic decisions. Now, of course, the Nick Stern report was written before all the financial turmoil of the last few weeks, and of course the whole issue is now open to reconsideration in a number of different ways. But what I hope I'm being able to draw to your attention in looking at these 3 examples is the fact that thinking of this 3rd example in particular, the climate change issue, it speaks to us about the realist theory that says in the wider world of international politics, the only law that applies is the law of the jungle, masquerading as negotiated international agreements to achieve maximum economic advantage. Getting out of unsustainable practices at the international level has a strong ethical imperative, but it's proved an intractable problem so far because negotiations have been based on the limited application of cooperative efforts as an outcome of self-interested agents. So, perhaps there's a malfunction in these summits. Perhaps there's something basically wrong. So my concluding remarks, first of all, let's remember that there have been some real successes internationally, and this is probably one of the best. That is, industry replaces the use of CFCs in refrigerators and other systems because of the growing problem of the ozone hole, which, had there been no controls, would have shot up like that. Here's the impact of the Montreal Protocol, here's the London Agreement, and here's the flattening out of the ozone hole layer, which will still take 100 years to repair, but at least it's stabilized. Now, this was the result of a treaty from which white-skinned populations will benefit more because of their greater vulnerability to skin cancer. And it was also observed, as we've seen earlier, in the recent success in modifying the Millennium Development Goals to include family planning. So there are international outcomes that can work and will work. But the second concluding comment really looks to the future and where we're going and what's happening with these international developments. And I want to draw your attention to the book of Jared Diamond, which I'm sure many of you read, Collapse, which came out a couple of years ago, in which he draws attention to the fact that there have been numerous societies that have collapsed. over the centuries because of climate change, because of galloping long-term reproductive growth rates, human environmental impacts, resource depletion, unstable trading relations, and socio-religious factors. The Mao in Easter Island, classic example, Maya, the city of Tikal, which I'll let Egon talk about, the Inuit and the kayak, the Rwanda genocide, classically overpopulation problem, resource depletion. However, there are some societies that have succeeded and not collapsed. Look at this guy in southwest China who's now making a business out of recycling waste from Europe, from discarded computers and electronic waste. Look at these guys down here in Montana, the state from which Jared Diamond comes, which have been supported by subsidies from other states to help them. And look at this group here, the poorer countries that have entered into the European community, the EU 25 in recent years, because the richer countries in the EU have brought them into the European Union with a view of raising and equilibrating their standard of living and their lifestyle. And Diamond's point is that survival in these areas which have collapsed, survival can be linked to how individual rights are subjugated to group interests. Even if those rights were fought for in previous generations, there is this change that can occur, and this is part of Diamond's point. And he makes the point, prevention in women's health presents a classic example of the importance of international cooperation to achieve ethical demands in the face of economic decisions. And some theorize that it's our ability to cooperate, the ability of humans to cooperate over the centuries, which is one of the main reasons why we've managed to survive in every ecosystem in the Earth. We've excelled in large-scale projects like transportation networks, energy networks, sending robots to Mars, mapping the human genome, and so on. And in all those cases, strong reciprocity was demanded. And so the point I'm wanting to make in contributing to this interesting discussion we've had over the last day or so is that to cooperate effectively, we're going to need to think much more deeply, in my view, out how to interpolate into our summits, into our international summits, and to reinforce the value systems based on humanitarian beliefs, often informed by religious values and philosophical values, because they have a significant role, in my view, in producing results by defining fruitful scenarios for cooperation. For example, 2009 will be the year when the Kyoto Protocol will be reconsidered, to be updated, to be upgraded, to be improved, to save us against what has been called the weapon of mass destruction, which is climate change. 2009 will be the international summit in Copenhagen, and we better get it right. Thank you, Chairman.
My name is Mark Bigdeman. It's very interesting to listen to all of you. But I think my question is specifically directed to Professor Oliveira da Silva. And it's a specific question regarding consciential refusal. And what is your opinion about the right of doctors or members of the medical team not, for instance, prescribing emergency contraception, not taking care of women asking for an abortion on conscientious reasons? I think it's an increasing problem, and you can see it mainly in the United States, but also I think you can see it in different parts of Europe as well.
Thank you very much for the question, Professor Mark Bigden. Let me just briefly answer. In my country, in general, and in Portugal, the conscious objection is allowed by law, so gynecologists, for instance, are not obliged to perform a legal abortion, and abortion is legal for social reasons until 10 weeks, and gynecologists or general practitioners are allowed not to prescribe emergency contraception. However, I must inform you and all the audience that emergency contraception can be bought in any pharmacy without prescription. So the question goes to pharmacists. There are some pharmacists that refuse to sell emergency contraception to young girls or for several reasons, either because they think it is abortifacient, although we know it's not. It only can avoid implantation. But I think that in abstract, the question you put is extremely important. We should assure mechanisms to implement moral diversity, ethical pluralism, and ethical tolerance, namely within sexual and reproductive health care. I totally agree with you. I don't know if I answered your question or if you want to dip it. If Chairman allows.
Well, I think there is reason to allow doctors to refuse to do things on a conscientious reason. But to me, conscience is a personal matter, and hospitals and others, or political, the government, they can't have conscientious reasons for not giving women the right to prescribe emergency contraception or to do abortion. I think the medical institutions have to give proper care to the women, and if there are not, and to be sure that there are sufficient personnel willing to do these things. And if you are against, for instance, prescribing emergency contraception, you have to immediately refer the patient to another doctor or another facility, so that the right of the woman will never be negatively influenced by a conscientious refusal.
Mm-hmm. Let me
That's
just
my
comment.
opinion, at least.
This is can I just answer in 30 seconds? This is extremely important, and for instance, we have hospitals in Portugal where all gynecologists refuse to perform an abortion. And as you said, the question either with the abortion, either with emergency contraception is, are doctors obliged or no to refer patients to another hospital or to another pharmacy. This is what in philosophy, I think Professor Mittelstrass knows much better than me, in ethical philosophy we call the cooperation. How far can we cooperate with something we are against? And classically, we distinguish between formal and material cooperation. Sometimes we can do material cooperation, but never formal cooperation. And then they split between direct and indirect. All philosophers have studied that since a long time ago. You know much more than me about that. If you want to speak about it, please.
I guess I'd like to make a comment and then ask a question of Dr. Stock, because it seemed to me today, and I don't believe I'm paranoid, that America sort of gets knocked a few times in the discussions. My name is Archer. I'm from Norfolk, Virginia. I acknowledge the fact that errors are significant issues in terms of health, particularly in individuals who are hospitalized and cannot defend themselves. In fact, Time magazine last year had an article about doctors who went to the hospital with their spouses to be sure that they were taken care of appropriately and would spend the night in the rooms. On top of that, in the United States, we have moved to an electronic medical record with the expectation that by doing this, we can reduce the errors in prescribing medication brought about by how the doctor writes, the interpretation of the dosing, et cetera, and put further controls on the nursing staff in the hospital in terms of double checking with what is occurring. Having said that, a recent hospital administrator wrote an article in the New England Journal arguing that he is in charge of 2 hospitals. The daytime hospital, which functions entirely differently from the nighttime hospital. The nighttime hospital is understaffed, staffed with individuals who are really antisocial, and that's why they're working at night. And the patients have less ability and activity to respond and get their demands met. So I guess after making that comment, my question is, the United States is trying to address these problems. Is there a comparable movement in the European Union to address these type of problems?
Yeah, I would like to comment on this from the Swedish side. We see exactly the same over-treatment, especially of old patients. A high frequency of the patients coming into the hospital have too many drugs and often competing against each other. And I think the rate in Sweden of the number of acute intake, especially in older patients, due to drug problems, too much or too bad doses or anything, or intoxications, is something like 10%. And we have also looked at the death rates due to this. And the things we discussed today to solve this is better education in pharmacology in the medical schools, in the nursing schools, follow-up of doctors and the nurses, even in old people's home. And also that one doctor, the GP, should be the one responsible for all the medication in the patient, and not the doctor in the hospital and the doctor in the GP and the doctor in a private practice, etc. Because this is one of the reasons for these multi-medications. But we have actually seen this problem, and there are fresh data from Sweden on this.
First of all, I don't know of any general movement we have in Europe. There might be individual movements someplace, but I don't know about them. You're raising an interesting point, by the way. We have accepted all over the years that the drug testing takes place in male volunteers aged 20, 23 or something like years. We don't, as much as we can, we avoid lactating women. In any case, with menstrual cyclists, we don't do these drug studies in the women. We don't even differentiate exactly between male and female in clinical trials. We have not fully understood female pharmacology. This is number one. Number two, we have hardly any data in old age with different metabolites. We know now that aging process is a highly individualized issue. But in our drug therapy, we don't care. The same is being true actually for children. If you think what we do with children, that we just calculate the dosage from the adults. And we have not the guts in ethical terms to do trials in old age and not the guts to do trials in children, because there is an ethical conflict which we cannot overcome. And therefore now, I think, well, what you said, I think is totally true. There's hydration, the water content of those old people, of course, is important. Nutrition is important, and the whole metabolic state is different, and we are not good enough in our clinical pharmacology. Let's call it this way. We have not taken awareness. We learned about women diseases, something like that, which are not cardiovascular, which are not considered properly. Gender physiology, gender pharmacology is just starting, and now we have to start old age pharmacology. Clinical pharmacology, I think it's more than time in an aging population. It's frightening how careless we overlook certain things because we don't have the guts to go for those issues, financially and ethically.
I'm sorry to say that we have to stop here. Ladies and gentlemen, dear colleagues, this session is in a way a continuation of the last session, dealing with ethical problems in medicine and related to medicine. It is a round table, not a round table discussion, and all colleagues taken part in this discussion have already been introduced, except Giuseppe Benignano. He is professor of obstetrics and gynecology at the University of Rome, Sapienza, and former Secretary General of the World Federation of Obstetrics. Professor Robert Edwards, who unfortunately couldn't come to Szeged, will be with us in a video presentation. Now, before we start with this presentation and our discussion, let me just make a few introductory remarks. Not about medicine of today, being just a philosopher doesn't qualify for any remarks of that kind, but about the ethics of tomorrow. Ethics has always been a central and legitimate topic of philosophy. Nevertheless, I agree with Günther Stock and many others that the great topics of tomorrow's medicine will be prevention, optimal therapy, and regeneration. Together with the growing efficiency of high-tech medicine, they lead to ethical problems which are not just of a medical, but of a general nature, as ethical problems in science. So let me start our discussion with some remarks on where in science, including medicine in its scientific aspects, ethical problems arise and what kind of ethical problems we are dealing with. There are, first of all, ethical problems that arise when scientific results are applied in the non-scientific world. One example, which was intensively discussed in the 60th and 70th of the last century, is nuclear research and the atomic bomb. Here, nuclear research, in its scientific character as basic research, leads to products whose manufacture and use create serious ethical problems. Can science and the academic world be held responsible for them? Secondly, there are ethical problems arising within research itself when investigating the nature of things, particularly when this investigation includes experimental techniques. Stem cell research and reproductive medicine are of this kind. They create ethical problems in the course of research itself, not only when its results are being applied. Remember the examples given by Professor Oliveira da Silva. Thirdly, as in other areas of human practice, falsehood and deceit also have their place in science. There are many examples, both in the history of science and today. Recall again the recent scandal which occurred in stem cell research in a South Korean institute, of how methods and results are manipulated, plagiarized, and publications are tampered with. If there is an ethos of the scientists and the scientific system, it is sometimes corrupted. Professor Stock and Professor Oliveira da Silva touched upon this in their papers. With respect of these kinds of ethical problems, the ethics of science, or ethics in science, has to deal with principles governing the relation between research and its applications, with principles of the internal ethical essence of research, and with principles which constitute an ethos in science and its institutions, nowadays often expressed in so-called codes of conduct. These principles and the problems they are applied to are often interrelated, as there is no such thing as an ethics of science which is a special ethics for scientists. Ethics is always an ethics of the citizen. It cannot be divided along social lines. That is to say, into a scientific ethics, which is the ethics of the scientist, and into a non-scientific ethics, which is the standard ethics of society as a whole. And the same holds for morals and the common sense. There are, strictly speaking, no closed ethical or moral worlds in each of which a single ethics or set of morals sway. We could also say that the problems an ethics of science or in science is dealing with, and the principles which guide this ethics form a triangle of ethics or morals. Its corners are application-oriented problems and principles, research-related problems and principles, and ethos-related problems and principles. Ethical problems within science or related to science are always problems which can be seen as problems moving within this triangle, with different and variable distances to its corners. And this triangle indeed opens a wide field for ethical problems of any kind in science, and for establishing ethical principles dealing with these problems. Also in medicine, which is much closer to the life world and to everyday's moral problems than other disciplines. And this is exactly the case when we speak about the medicine of today and the ethics of tomorrow. What happens and will happen in medicine, in medical research, and what are and will be the ethical problems related to it. Let us now start our discussion with listening to Professor Edwards. You give an introduction.
First of all, I must assure you how very, very sad Professor Edwards is that he can't be here. He was very, very much looking forward to this meeting. And I'm sure you all know how enthusiastically and vigorously he would have contributed to the whole meeting, but in particular to this discussion this afternoon. He's very happy to be with you, however, in virtual reality. And I'm sure you will all agree, we know that he has always been a man of vision. And I know that Professor Dick Faluzzi can come up with at least 1,000 quotes exemplifying what a visionary man Bob Edwards is. And so during the last year, he became fascinated with the idea of regeneration and the molecular control of regeneration. And he spent about 6 months working very hard to write a very in-depth review that some of you will have seen or read. And so earlier this year, we put together a little podcast asking Bob questions about this review and about his views about the future of medicine. So this is what we're going to show you now.
Stem cells develop and grow, most of them, what we call the inner cell mass in the blastocyst. The blastocyst is a round structure with on the outside a single layer of cells called trophectoderm, which forms the placenta. And inside there's a group of cells called the inner cell mass, which forms the tissues of the body. And in Glasgow, in, let's see, when was it? 1963, my colleagues John Paul and Robin Cole and I took out the inner cell mass and grew it in vitro. And to our amazement, if we left it with cells underneath it which are feeding it, it formed blood islands, muscle, connective tissue, every tissue in the body. And we're saying to each other, what the hell's going on? These are growing forever. Moreover, if you take them separately, don't put the stuff in the cells to support them, you just grow them separately. They divided and divided and divided. We said, they're immortal. We said that it's unbelievable. Nobody will believe what we've said. This repair was discovered, is it by Spallanzani, the Italian? And he found salamanders did this. And they had a pond, and salamanders swim in it and wanted to get rid of them. So they went and started cutting their legs off and things, and hitting them on the head and things. Okay. And then they went to have dinner, and a week later they found there were more there than when they'd started. Now the salamanders are unusual, because like other species, which are grouped together and called urodeals, they all have one characteristic, and that is that if you chop off their legs or their tails or whatever, they can repair them again. And we were very lucky when Dr. Heba Katz discovered it in her laboratory, where she was studying immunology, that she made holes in the ears, which is how we identify the mice, the controls were treated. And to her amazement, 5 days after she clipped the holes in the ear, her assistant told her, there are no holes here. Have you done something to them? And Heba said, no, I haven't touched them at all. So decided, it must mean that ear has healed itself. And so when she looked and found that the ear holes are blocked up, she thought, I must have mice that are the same as urodeals. Mm-hmm. She wanted to know now. So they set up a big experiment. And in every case, the control was blank, holes were still there. And in the ones that had been clipped, all the holes had been repaired. So she knew then that she could repair the ear in the mouse. So she went to the heart and stabbed the heart, and came back 5 days later. And the central nervous nervous system told her it came back 10 days later. And then later on, we found it would happen with the liver and kidney and every tissue in the body, which made me say this is wholesale repair, no need for stem cells. Oh, here's a picture. There's the MRL mouse. You can see it, can't you? Mm-hmm. And that's there you can see where it's controls, where the holes are still there, mm-hmm. and there where they're healed. There it's started when injected, and there it's closed. You see. I won't go into this. It's the same as that in detail. I think you'll have to ask Dr. Heba Katz for that. We know they live long. Their tissues live longer. But whether the whole animal lives longer will be a very good question. Why can't you do this in humans? Mm-hmm. And everybody said no, until one person found that when you looked at a fetus, if we clipped off the fingertip, it grew again. So we knew now that the humans could grow like a salamanders. But the reason was, why don't they? And the answer's got to be that the two species have the same genes, but in the human, it's still been cut off. Then to everybody's surprise, they found or suspected it may be due to be RNAi, which is suppresses DNA activity, or it may be changes in chromatin in your cells, which is a very fast-acting compound and very reliable. The stem cells develop from the inner cell mass. That's right. Where the blastema develops from a group of cells that form a little group, bit of tissue at the top. Then they multiply when they get a stimulus from below. So the two are not quite the same. They probably have the same endpoint, but they are different in how they originate. I've often wondered, suppose a blastema does something, but it can't repair it. For example, suppose you get a mouse with a gene defect. and then it goes and repairs itself. And when they put in stem cells in there, you could repair the mouse again by a different route. And in fact, I think that's the way it will go. Not only stem cells, but also what you call stem cells from the cord blood stem cells. They're they're like an embryo stem cells. And also by what they call tissue stem cells, which are taken from different tissues in the ordinary body, and they will grow into stem cells as well. Well, the great advantage of those is that you can get them from a mother, and their genes will be similar to the children. So they won't be rejected if you put them into the child, if you inject them into the child when the child's sick. So they have advantage, which may leave blasphemers standing who would fool around making a blasphemer if the cord blood stem cells would work quite independently. I think it could. I think it could. We don't know what's in the future. Look how we've moved in stem cells in about 30 years. I think everything's possible. Now this is the most fundamental question. Because you start fiddling around with the brain, then you're in control of things like memory and love and hatred, you know. See, that's a picture, that's a blasphemer. There, with all the stem cells there.
Right.
This is connective tissue, and these are blood vessels in here, in the things. And this here is the limb. And the question is, it says the mature limb harbors a gradient of positional information. As you go along there, where you cut it off starts to remember what it was there before, which is miraculous to me. Well, if you go to the brain and say the same thing, if you can restore all these things, if this is the brain, could these things have memory? That's the... I don't think you need a psychologist. I think you just got to start at the beginning there.
Okay.
Just do it on mice. And maybe in animals to show some intelligence if we can and see exactly what happens. Something you can measure exactly, where you've got to know the genes and everything, then we may be doing it. But very little difference, I would say, because we know very well that when you look at many cancers, you find in there that they've formed all sorts of different tissues within themselves. And these, of course, are ones that will cause fatalities and lead to death. Now, in the stem cells, they grow from inner cell mass, which is perfectly normal, and by our efforts to take them out. And, of course, this is very artificial. Well, there's been a lot of debate about this, because there are very well-known pathways. For example, when the sperm is being formed, the very early stages are formed in the embryo, but they migrate through different tissues in the embryo. Then they finally end up on what we call the genital ridge, which is the precursor of the testis or the ovary, you see. And therefore we know that the stem cells can move and migrate. There seems to be a knack of the stem cell to find its way home all by itself.
Thank you very much. Perhaps Professor Benaggiano, who has not yet spoken to us, should start our discussion with his statement.
5 minutes? Well, if you like 5 minutes. Well, I think that the only contribution that I can make is, of course, in the field of reproduction because of what I have been doing. And in the field of reproduction ethics, I think that John Harris said it very well, because he said almost at every step there is a conflict, or there can be a conflict, between individuals and society. Society wishing to regulate somehow, and individuals who are infertile wishing to do just about everything conceivable in order to conceive. I think there is a reason why this conflict can arise. And the reason is the unique situation where there is a silent third party whose interests and rights must somehow be protected. And who can protect them? Even back in, 1899, when the Embryo and Fertilization Act was in the Warnock Committee, it's written there that not always the two prospective parents can be the best to evaluate what protection the offspring should have. So we have there a major problem, and also the whole thing is complicated by the fact that at least the major monotheistic religions have a very special, always had a very special focus on the beginning of life, on the origin of life, on the fact that this is a sacred moment, and therefore that they have a right, God-sent right, to intervene and regulate from their point of view. And unfortunately, I think that the 21st century, if somebody had asked me 15 years ago, at the time the Berlin Wall collapsed, what would be the most incredible feature of the 21st century, I could have come up with 25 options, but that of a world gripped by fundamentalism would not have come to my mind. And yet this is what we see day after day, and of course religious fundamentalism is one, and is one that tries to force the view of that particular religion on everyone, and not only on the followers of that religion, which is why I can call it fundamentalism, because a religion has a perfect right to say to each religion, to their followers, here are the rules, and these are moral rules, and you shouldn't go around them. But when we hear that each religion wishes to go beyond their own followers and set rules for everyone, including those who simply don't share those views, I think we have another problem. And problems can only grow. Bob was alluding to some of the new avenues that human reproduction is already taking. And I was very impressed by an article by person in Nature a few months ago, and I'm looking at Regine Citruk-Var because she was one of the persons interviewed for that article, where people very clearly said in the not too distant future, by reprogramming cells, we will be able to make parents out of neonatal infants or 100-years-old people. Now, assuming that this will one day be possible, what kind of ethical consideration, concern, and limitations should be imposed upon these things? And we know that society, from the United Nations down to basically every country, has come up against reproductive cloning. A few scientists are debating whether in the future that might become an option, but at the overall level, I remember when I was working in WHO, so this must have been 1996, 1997, the WHO passed a resolution to condemn every form of reproductive cloning, and there was one country that voted against, and that country was, of all, Zimbabwe. And they voted against because the resolution was not strong enough. So we see already a lot of reluctance. But the reluctance, in my view, is absolutely normal if you think of reproduction as something that has gone on for hundreds of thousands of years exactly in the same way. And then 50 years ago, not more, we were able to have sex without reproduction. And 25 years later, we were able, and Bob Edwards is the father of all of this, to have reproduction without sex. Then we went on for reproduction in menopause, even though this is ovum donation. But a group led by Dr. Perez has started publishing results with knocking out the BAX gene, and at least in mice, they are able to prolong the reproductive lives of those animals, and I see no reason why, by moving along those lines, we couldn't prolong the reproductive life of women. Now, at least with women, we have a stumbling block, and that is the quality of the eggs. Because if, and I got a phone call of a patient of mine who at 43 became pregnant by herself, and then within 4-6 weeks, she had a miscarriage, silent, and she was ready to go for all of the tests. And I had to tell her, but this is 40%. At your age, abortion, miscarriage is 40%. So I don't know how that can be taken care of and dealt with, but we are at the beginning of an era where, and there is a book that says everything conceivable. So you can conceive everything conceivable, and I'm sure that at least from the scientific point of view, we will be able to do things that are almost unbelievable today. But shall we move in that direction? What boundaries have to be? What defense mechanisms against endangering the newborn, the newborn, the being to be conceived? And I don't see any answer to any of these things, so I'm more than happy to pass on and see if anybody has answers.
Yes, this is my question to you. Would you like to keep up with that ball?
Yes, thank you very much. I was very interested in your comments. A little concerned that you draw the distinction between science and religion as a situation of conflict, because I don't see it like that. I see it as a situation of conversation. You know well that the idea that monotheistic religions are concerned about identifying the moment of the start of life, that it was Aristotle who made it quite clear, and it was accepted for nearly 2,000 years by the church, that the point of the start of life was about 40 days for males and 60 days for females, because females were that much more complicated. But that was all reversed by Pope Pius IX in 1867, who decided that the moment of the beginning of life was the moment of fertilization. And of course, in my view, the science informs faith, it informs religion, and the science now tells us that that was wrong. And Pope Pius IX was not backed up by science, he was backed up by a dogmatic statement. And the science now tells us that quite clearly there's a distinction to be drawn between the moment of genetic identity as was drawn out by the Warnock Commission and by Anne McLaren and many other people, and the moment, which was at the moment of fertilization, and the time of personal individuation, which is around the primitive streak stage. And the more that the science is advanced in this area, the more secure that has become, in my view. And therefore, I think it's a much more nuanced approach that we have to take in terms of the way in which science informs faith, and faith has to respond to that in the way that it did ultimately with Galileo. And Cardinal Bellarmine made it quite clear that if the science is telling the faith, is telling your dogma that there is something that is incompatible with the scientific knowledge, then there has to be an accommodation of that new scientific position. Now, to my mind, that actually I find extremely helpful in terms of understanding the beginning of life and those very early stages, and it gives a very different picture.
Would you agree, I mean, referring to what you said, that there is no definite answer to the question when life begins, either from biology or from medicine or from philosophy, even religion? And this means conversation between these different areas is the answer.
Yes, I agree very much, Jürgen. I was hoping that I was able to push you as a philosopher to give us the answer. But I do agree, and I think there's a great danger that in this whole ethical debate, in which I've been deeply involved for quite a long time, it is helpful if we maintain this conversation and explore the conversation more deeply, rather than find ourselves confrontational, where we make very little progress. And I think that that will help to illuminate some of this debate. In that context, I think, again, I'm speaking personally, I find this a helpful aspect of the stem cell debate in terms of the use of human embryos for the derivation of embryonic stem cells. However, I'm sure we all know in this room that whole area is currently under immense change because of the possibility now of introducing genes into adult cells, which would then reprogram them to become embryonic stem cells, so we won't have to use blastocysts in the future, perhaps. But if I could just add one point, because I debated this recently with President Bush's advisor on stem cells in Cambridge, Bill Hurlbut, and I was pro-stem cell derivation, embryonic stem cells, and Bill Hurlbut is pro-ANT, altered nuclear transfer, to try to avoid the use of blastocysts. And the question was asked, are there any new ethical questions to consider in this debate? And a distinguished philosopher from the UK, Baroness Honora O'Neill, said that she thought there was no new ethical question in this area except for one thing, and that is that as a result of the experiment that created Dolly, which was in the Institute in Rosslyn in Edinburgh, where I used to be a director, that experiment demonstrated to us that when we rub our hands together and we release cells into the environment, those cells have the potential to become an individual. And her view was that that was the only new ethical dimension that is thrown up by this particular area of research.
Thank you, Professor Oliveira. Professor Stock.
I would like to follow up on this. I think we had an easy time when we could fight about the origin of the stem cells. That was very easy. Now, since we can reprogram, the potentiality comes up, and that's not the origin. And just to follow up on this potentiality now brings back the question, is egg something we have to care about? And if we think about the waste of eggs
in the course of a life of a woman, in the beginning already, in development. If we then have to ask the question, are sperms already potential life? This is an enormous waste of potential life, which we do. Not to talk about the more difficult question here with dermal cells. So I like that we come back to the issue that we cannot answer your question. I like it because it brings us back to the fact that we have to use conventions. We will not be able to have an ethical dialogue without certain conventions which we have to fight for. And especially the question shows that we need new conventions or probably old conventions, but we cannot believe that science will give us a definite answer on this topic. This would be my...
Thank you. I would like just to follow and underline the importance of Professor Giuseppe Benagene's questions and also of my colleagues, and try to distinguish as possible the question between science and philosophy, or science and religion. When we ask, when does a human life start? I think this is a scientific question, and there is no doubt about it. Human life starts with conception, that's clear. But human life is not a human person. And this is a scientific, or if you want, a religious question. When starts a human person? This is not a scientific question, but of course, the answer we are going to give has to be informed by science. Most people agree that a human person has to have at least the brainstem working, so at least the beginning of the central nervous system has to start being working. And if we put all our decisions at the moment of conception, we support the so-called genetic determinism, and we see some people trying to rewrite even scientific definitions. For instance, when we read some documents saying that the pregnancy starts in conception. No, the pregnancy does not start with conception. Pregnancy starts 7 years later with the implantation. So far, in order to have a pregnancy, we need a uterus of a live woman. And for instance, when we read the famous Humanae Vitae encyclica, where the Pope Paul VI crosses the border toward the science, it's clearly stated an invitation he made for scientists in order to make easier and more accessible all natural methods. And if you read also, again, crossing the border from religion to science, the famous speech of the actual Pope last May 10, 2008, 5 months ago, where he says, according to the new data of science, we confirm all the previous conclusions of Humanae Vitae, but he doesn't explicit which are the new data of science. Nobody knows, probably he knows. Although I strongly respect Joseph Ratzinger, that's not the point. So I think that the big point for this question is when theology wants to talk as science, and sometimes scientists can do the same. When science wants to talk as theologians, things do not work.
If I leave the question between the relation between ethics and theology aside for a moment, two things Gunter Stock said. I mean, ethics means always conventions. There is no absolute truth in moral contexts. This might be one thing, but conventions could all... The crucial question then is just convention, or what about the reasons given for? And there are better ones and others. Professor Oliveira da Silva asked an interesting question in his contribution. He asked, do ethical values change with time? Well, the answer might be yes, at least some ethical values change. The more interesting question in our context would certainly be change ethical values with respect to science, following science. Or let me put the question the following way. Does or should science learn from ethics? And does or should ethics learn from science? I think this is the particular situation we are faced with at the moment. Would somebody like to comment on that? No?
Dr. Bückemann made the point. He asked how societies behave when there are desperate women and need emergency contraception. And if the Dr. X is not prepared, and if Dr. XYZ is also not prepared, if this is this kind of pseudo-ethical dictatorship, then I think science should override.
Yes, certainly.
To Professor Brian Heap and the so-called conflict between religion and science, I don't think there is a conflict, but I think that there are a lot of people who spend their time creating conflicts, and that's not the same thing. Personally, I think I spent at least the last 10 years of my life trying to create a dialogue, trying to say, you take into consideration scientific truth for what they are worth, because they change continuously whether we like it or not. But we will try and take into consideration ethical issues as you guys, the philosophers, the theologians, can come up with. And I know that Galilei was finally vindicated. It's 350 years later. I hope for something a bit more speedy in the process. So I personally hope, but don't have much hope, that in the present climate, which I called fundamentalist, a dialogue is possible. I personally, and it should have no bearing here, but to clear your mind, I am a believer. And so I don't want conflicts between religion and I work to promote dialogue, but when the story of the Humanae Vitae, we now know that in humans, reproduction has many other meanings, that reproduction is not indissolubly bound to the sexual relation. If on the other side we have people who say, no, we continue to think this way against scientific knowledge, then the dialogue becomes almost impossible.
Brian?
Thank you. I suppose perhaps coming from the UK, I may be a little oversensitive because we do have a lot of fundamentalist scientists in the UK, starting with Richard Dawkins. And we also, and I know that there are also a lot of very fundamentalist scientists in the USA. And so we have the New Atheist movement. And I quite agree with your point that, unfortunately, this tension that between science and religion has become very acute because of the positions that are adopted, particularly on the extremes. And I'm delighted and share your experience as a believer in seeking to try to work through these difficult issues, in my case from a Christian point of view, and clearly in your case also, because I do believe that our faith is informed by the science. And this is why I'd just like to pick up this point about ethics being influenced by science, going back to Professor De Silva's point, because I think we have to be very careful in terms of the words we use here. The moment when the sperm enters the egg, we understand as fertilization, not conception. The moment of implantation we understand as the moment of conception, and we talk about the products of conception, which includes the placenta. And the reason why I think that the science influences and informs our ethics in this particular area is because I cannot get over the problem which we are faced with, that up until about day 14, the blastocyst can split into 2 or even into 3. And before day 14, we cannot be sure whether we're dealing with a single pregnancy, identical twin pregnancy, or exceptionally 3 embryos. And for that reason, I find it extremely difficult to accept the view that everything belongs at the moment of fertilization. And I could develop this further because there's a lot of scientific information that one needs to bring into this in terms of the programming that occurs over this period up until the formation of the primitive streak. And I find it much more compatible to see this important distinction between the genetic and the personal identity that I described previously. This isn't an original idea. It's an idea that's been put forward by many distinguished geneticists, and I'm just wanting to reinforce it in terms of the way in which I think it does actually start to inform our ethical debate, Jürgen.
Actually, I want to change gears. We are now having an ethical problem which is not easy to resolve. There are others around, and during this meeting we heard some of them which can be tackled and nevertheless are ethical issues. And if I may, I would start with ethics of language. When you showed the quotation of Watson, and this was not the only stupid sentence he made, but when he talked in context with Edward's application of infanticide, I think this was awful. This is not a language which should be used by scientists. Now my next point is, when Edwards was asked about immortalization with stem cell research, I wondered if a scientist could answer so easily such a fundamental question. I consider this very lightly said because there is no indication that it is true. It is thinkable. But this is Jules Verne. This is not scientists' view, and we must be very careful as scientists, especially if we are prestigious scientists, what we speak. And just to make another point, which I made already during lunch, gynecologists, IVF people should not talk about embryo transfer. It's transfer of fertilized eggs. We fight like hell in the stem cell area to make these embryos fertilized eggs what they are. And now you come along and just use the word like nothing. This is impossible. We have to think about how we speak. My next point, also from today, is how do we treat elder people? This is an ethical problem. It's a tremendous ethical problem. We just don't care. We sit and wait until they fade away. This is what we do. And this is real ethics, what we talk about. We have no guts to discuss. Cosignani made the point. The last 6 months, I think we spent the majority of healthcare costs. We don't have the guts to make clear decisions during the nearer the death. We don't have the guts to have an ethical dialogue, really, to make something happen. And we other in Europe, we don't like the British attitude that with 65, certain surgeries you don't receive any longer. But this is not a statement which is valid in a society where we have a middle aging population of 86 and 90 years. We must come to grips, and we can. But we should attack those things. Assisted reproduction. In Germany, we cannot even look at the fertilized egg, not to speak about a proper diagnosis there. And then, in the extreme, after implantation, we are bored again. This is ridiculous. These are issues which are at hand in a society where we know that IVF is an important is an important feature of our future if we want to have a future. These are issues which I really would like to see, and then we all, not Germany, we all don't dare to ask for research money for IVF research. We need molecular research to better understand what we do with IVF. We have the artistic approach, but we don't have the basic science approach. And why? Because we do not dare to ask for real money for research in this field, because it is not politically correct. These are all ethical issues we should address today. And finally, the $1,000 genome is coming. By not looking at it, by not taking care of it, it will come anyhow. And we must train. In time, we must train the people. And just to say, no, this is stupid, this will not help. We must train people to go about with risk-benefit analysis on all those issues. We can do something. But instead, we discuss widely about stem cell research. This is a nice topic, but the real issues are somehow avoided. Sorry for that.
That's a broad field of problems and questions. But as a matter of fact, I mean, if you agree to the distinction I tried to make between different problem areas with respect to ethics and science, we have dealt in a way in this discussion and in many papers with ethical problems related to the results, the products of science or scientific research. We have also dealt with problems which arise within research, in doing research, and some of these the remarks of Günther's were in that direction. What about, and again, talking about the language of our ethical or scientific discourse, touches this third field, dealing with the ethos of the scientist. Can a lesson be taken from your example, or to put it in another way, is or should the ethos of a scientist, the language, particularly the ethical or the ethical language of a scientist, should it be an issue of university teaching? And if yes, what do we have to do?
Very good question. Yes, no doubt. First of all, we should teach our students since the pre-graduation, even the medical students, biological students, we should teach them about the recent and not so recent history, sharing with them the success cases and the bad cases, as the Wang situation I explained to you, I shared with all of us about the stem cell research. Probably that's not enough. If we read the Menon from Plato, it starts with a question. What about the virtues? The virtues are inherited, or they are taught, or can we discuss about them? Can we learn? We acquire them from our parents? This is the first sentence of the Menon of Plato. So it's an old question. The question is, when teaching and sharing and discussing with our students the recent cases of the ethos of scientists, the good and bad examples, do we improve their ethical sensibility? That's the point. Amazingly, there are several studies conducted in different faculties in the United Kingdom, in America, in other European countries, where if we can use this expression, ethical sensibility, we have to define it and measure, extremely difficult. But if we can use these concepts, amazingly, the ethical sensibility of medical students decreases since the first year until the fifth. That's not very optimistic.
I think it is interesting how virtue is coming back into the vocabulary, and the issue of truthfulness and truth-seeking is a particularly key point here, and especially when we're faced with the fraud claims that are made. I thought it was interesting in a recent issue of Nature that a move is being made to actually introduce an evaluation in journals of how many articles carry an element of fraud. It's going to be extremely difficult to do, but at least somebody is asking this question of actual, and of course this is one of the areas that has to be brought out very strongly in teaching students in this area. Of course, we also have to make them aware of the pressures that they will be under as they seek to apply for grant funding to carry out their research. But one of the great anomalies I found, if I might turn to my German colleague, is just to take the stem cell issue again, in that although stem cell research is prohibited in Germany in many respects, on the other hand, it is possible to import stem cell lines from other countries. And I put it to some of the key German lawyers in the respect. Where do the virtue ethics sit in relation to ethics informing decisions that are made concerning the scientific pursuit?
That's a completely ridiculous situation. Yeah.
Both Brian Heap and Gunther Stock, without naming, they threw into the discussion another protagonist, and that's politics or the politicians. And I know that the incredible vagaries of some of our laws that pretend to be ethical are due to the fact that one politician needed to follow that particular line because it was expedient for him without any ethical consideration whatsoever. And even, I think it happened 6 or 7 years ago, I can even say it, but the head of the Parliamentary Committee on Health told me, I told him, look, this doesn't make any sense. And you said, are you telling me? But the Prime Minister called me at 7:30 in the morning and said, you don't change one iota. So, at least in some countries, politics and politicians are more powerful than all of us together.
Well, we have always been in time during these 2 days. We should also be in time with this session. I think it was quite exciting, also this discussion, very, very short discussion. I mean, when we discussed the question of truth and truthfulness, the ethos of the scientist, perhaps something we have to learn again is that science, doing science, has at least 3 meanings. Science as a particular form of knowledge, what we call scientific knowledge. Science as an institution, this is also clear, but science also as something like a life form, something we live as scientists. And we owe, being scientists, we owe an example to our students. And if we realize this and follow this, then also ethical or moral questions related to science and research may be able to be answered. Well, thank you very much indeed, all of you, and thank you for your patience.
we start with handing over the poster prizes, and I have Professor Mancuso and Professor Benedek who will perform this duty.
Well, the Commission has examined all the posters, and it was quite difficult to decide because they were very good results of research. So we have decided to select 3 posters. And, well, at the meantime, I have to say that the prize for these posters has been decided by Professor Benning, who decided to put 1,000 euros for the 3 posters, giving the first prize of 500 euros, the second 300, and the third one 200 euros. So I'm going to give you the results of this selection. And the third prize will go to the poster number 9 by the title of Congenital Heart Defects and Other Abnormalities in Fetuses with Increased Nuchal Translucence. We found that this research was quite original because in absence of chromosomal aberrations, the nuchal translucency may predict some heart defect and some other minor malformations. So I think this is the reason it was selected, this poster. And the second one was the poster number 2, by the title of Improving the Risk Factor Profile in Metabolic Syndrome by Using Physical Activity Monitors. And the group is from the University of West Timișoara in Romania. Excuse me, I didn't say that the third one was a research conducted here in Hungary at the University of Debrecen. The first name is Dr. Orosz. And finally, the first prize was decided to the poster number 7 by the title Pregnancy-Induced Hypertension, In Vitro Fertilization and Mother's Age. Is there a link? So we decided all together in the commission that this was a first prize poster worth to give. Thank you very much.
Please step forward, please. Orosz László, third prize. Claudia Avram, second prize. Congratulations.
Thank you very much.
And the first prize to Dunja Lonkal. It's that. Congratulations.
I don't like the Dunja launcher, but she must go yesterday. Thank you very much.
Just a moment, a technical request to the awardees that they find a receipt in the envelope. They should sign it now and give it at the registration desk to Director Nagy, the director of the organization. This is just a financial matter. Please do that. So, ladies and gentlemen, since I have the microphone, I take the occasion to say some closing remarks according to the program. Since we are lagging behind time, so I have the excuse why I will be short, just like Charles I. So, ladies and gentlemen, we are over the second meeting of the Egon and Anditz Fellowship Foundation in Szeged. I think everybody knows that it's quite easy to organize the first conference, but it's the most difficult task to organize the second one when the first enthusiasm is over. And since we are over the second conference, I'm quite sure that there will be lots and lots of these fellowship conferences, maybe at this place. So, just to repeat the task, the purpose of the foundation is supporting scientific work conducted in the field of improving reproductive health, under the words of empathy, science, and hope. I think that during the last days, we could get evidence that this foundation really works under empathy, science, and hope. Moreover, the ideas of the foundation, they extended the borders of reproductive health. Egon and Anditz Fellowship, they thought of some much wider field than reproductive health. Egon Anditz Fellowship is a typical example of a humanitarian. To tell the truth, now I understand the word, what humanitarian means. So I can proudly report to the conference that yesterday the aim of the conference is very extended to an similarly idealist and humanitarian path. So yesterday we signed an agreement between Szeged, Novi Sad, and Timisoara. These are the three universities that are neighboring each other. They seem quite close. The only problem is that for 80 years we had rather strict political borders which did not connect but separated the inhabitants of the three countries and the three universities. So now we have the hope that in a couple of years the United Europe will eliminate again this border, and we will live in a very small regional community where we will have the freedom to work, live, study in Szeged, Novi Sad, or Timisoara. Now the three universities decided to unite their power and to work together for the development of this region, including the health system, the ethical system, and the education and science. This, don't have to emphasize, this was originally the idea of Egon Anditz Fellowship, and I'm very happy that we could achieve that. The document has been signed yesterday, and the action actually started much before. So there are some joint project proposals, and I hope that next year we can report some other success. So the other point what I wanted to talk about was that you might know that Egon Dietz-Farushi donated his precious South American sculpture collection to the University of Szeged, to the Faculty of Medicine. So these nice sculptures, they are in the Dean's office, and I can propose that the next meeting should take into the program to visit this beautiful collection. This is my favorite piece. This is, according to Egon, this is a tiger. I'm not sure, I'm not a biologist, but what you can see that this is quite glossy, the tiger, because this is the bad habit of the Dean, that every day when I pass the tiger, I always stroke her just to get some energy, maybe something, but energy which keeps Egon running for a long time. Now, I think almost everybody here is a friend of Egon Dietz-Farushi. So let me ask you whether anybody recognizes this guy? So, he is Rabindranath Tagore. So I think he is the favorite thinker of Egon, and I collected some thoughts which might suit this occasion. I slept and dreamt that life was joy. I awoke and saw that the life was service. I acted and behold, service was joy. And another idea, man's abiding happiness is not in getting anything, but in giving himself up to what is greater than himself, to ideas which are larger than his individual life, the idea of his country, country, humanity, of God. So, ladies and gentlemen, the conference is slowly over. What I can wish, it's written on the slide. See you, Egon, same time next year. And for all the participants, on behalf of the University of Szeged, Faculty of Medicine, see you same time next year. Ladies and gentlemen, everybody is invited to have a reception in the Szeged Castle as a guest of the Faculty of Medicine. Thank you very much.
I'm now calling upon Professor Pal and Professor Dietz-Farushi to give the farewell to all of us.
T.S. Eliot writes somewhere that the only wisdom we can hope to acquire is the wisdom of modesty and humbleness. And modesty is without limits. And that example is when Professor Benedek stated that it was my idea, which was really his idea, or in the best case, a joint idea. And I hope that you understood that we tried to cover a very broad field. We were told that it is nonsensical, that people will not keep their allotted time. I must say that you did, all of you, and this was what I was convinced of. And that we also tried to penetrate some very complicated questions. And when you start asking those questions, there is no end to the discussion. And I propose to you that it is because human nature is an intricate mixture of rationalism and irrationalism. And as Bertrand Russell said that without the emotional element, life would be dull and not worth living. But with it, it is extremely dangerous. And we have seen our limitations, but look back in history. Look back in 15,000 years ago, there was no agriculture whatsoever. People were living in caves. See where we are. So there is an inbuilt talent in the Homo sapiens, which will certainly prevail. And we hope that even this symposia will survive, and especially will survive me.
Thank you very much. Dear colleagues, one of the best speakers whom I ever seen is Professor Ditzfalusi, and now I have to speak after him. Professor Benedek, excellent speaker, and I am the third one here. So it is a little bit difficult to tell me some interesting words. So I would like to tell some sentences only about four things. First one is that at the beginning I hoped that it will be, as it was true, very, very good, very well organized, I think so, and conference with a very high scientific level. The second one was important for me, which was showed by our dean, that among these three countries, Romania, Hungary, and Serbia, I hope became a deep connection, not only just speak about the life, but we have to do something too. This was the second one. The third one, which was important for me, that there was 15 posters. It means, and these posters are from young colleagues. It means that the young colleagues became to be interested in our scientific meeting, and I very hope that in the future it will be better. More higher number of young colleagues will be here together us, because of, at least, I think this is the main aim of the foundation of Ditzfalusi Foundation. The next one is that today afternoon we spoke about that we have to prepare new aims, and it would be that during these 2 days we try to organize special postgraduate conferences, scientific meetings, especially for the young colleagues. So I think these four things which were very important for me. And now as a president of the foundation, I would like to close the conference and to say goodbye for everybody. Thank you very much.